I'm there. आप नहीं देख पा रहे क्या?
मैं लाइव कर दूंगा, अभी लाइव कर रहा हूँ।
मुझे बताना करने से पहले।
लाइव है अभी।
Thank you. Hello everyone. Am I live? Can you see me? Can you hear me? Can someone reply in the comment section? Give me a minute. If I'm clearly visible, audible, can we start the session ahead? Are you people there? Just a second. I guess there is a little bit lag. I'm waiting for your comments. If I'm clearly visible, audible, I will start the session ahead. Yes. Thank you, Radhika. Thank you so much for replying. So I welcome you all for today's session. A very good evening to all of you. I am Dr. Priyanka 𝗧𝗲𝗹𝗲 here, and today I am going to take the PYQs for FMGE students, specifically from the pathology. So from the pathology we are going to cover, we will try in the next 3 hours to cover at least 5 or 6 papers. All the questions of the pathology paper wise we are going to take. So, you know, in your exams, most of the questions are repeat questions. They are not actually repeat questions, they are repeat topics. So what I am going to cover now, with that, whatever the question we will discuss, we will not discuss that question and answer only. We will discuss that topic completely. So if any other question also from that topic coming in your exam, you will be able to crack it very easily. So let's cover. In the next 3 hours, I am going to try to give you 50 important, ultra important topics. Question wise we will see. So without wasting any further time, I guess we should start question by question, and I can challenge it will be an ultra useful session for you. So if you are giving your time for 3 hours, it will be worth giving, and I can guarantee that after the session you will be super confident in the pathology, and maximum questions in your exam will be from these topics only. I cannot say the same questions, but the topics will be these only. These are highly repeated topics, highly. In every exam, in every paper of you, these topics questions are always there. So let's start it. Okay, so you people are with me? Can we start? So the first question is in front of you. Which of these is nephritic syndrome? So you always get a question on nephritic versus nephrotic syndrome, very commonly asked question. Let's start it. Which of the following is a nephritic syndrome? The options are minimal change disease, membranous glomerulopathy, post-infectious glomerulonephritis, focal segmental glomerulosclerosis, that is MCD, that is MGN, that is post-streptococcal glomerulonephritis. Post-infectious is post-streptococcal only, and this is focal segmental glomerulosclerosis. So can anyone tell what is the correct answer? Yes, I guess you are right. What is the correct answer? Can you write down in the comment box? Yes, most of you are right. The correct answer is C. So here the question is regarding the examples of nephritic syndrome. But according to me, you should know completely. Now, what is nephritic? What is nephrotic syndrome? There are two syndromes, nephritic syndrome and nephrotic syndrome. So listen, nephritic and nephrotic syndrome are not one disease. It is a group of disease. So I will tell you, in nephritic syndrome, there are 5 symptoms. Any patient presented with that 5 symptoms, we say that disease is nephritic syndrome. And in nephrotic syndrome, I am going to tell you a cluster of 6 symptoms. So let's start with nephritic syndrome. In nephritic syndrome, there are 5 symptoms, 5 clinical features. So any patient coming to you with hematuria. What do you mean by hematuria? Hematuria means hematuria. It means blood in urine. Blood in urine is known as hematuria. So any patient coming to you, doctor, my urine is red. I'm having blood in my urine. Coca-Cola color urine, black urine, red urine, smoky urine. The meaning is same. 𝗏𝗍𝒄 cast in the urine. These are the clues given to you in various questions. Okay. So that is indicating the examiner is pointing you towards the nephritic syndrome. Okay. The second is the proteinuria. Proteinuria means protein, urea. That is protein in urine. It means protein in urine. The third is hypertension, that is blood pressure is more than 120/80. The next is the edema. The patient will have edema specifically on the face, you know, and it is around the orbits, periorbital edema, it is said. And last one is oliguria. Oliguria means in 24 hours the urine output is less than 500 ml per 24 hours. If any patient presented with these 5 symptoms, the patient is said that he is having nephritic syndrome. So there are many types of glomerulonephritis. I assume you know the classifications of glomerulonephritis. So there are primary, secondary, there are many types of glomerulonephritis. Now some of them present with nephritic syndrome, Some of them present with nephrotic syndrome. Now you may be thinking, ma'am, what is the reason for these 5? So let me draw a diagram to explain you the reason of all these 5. First, learn the 5 clusters together: hematuria, proteinuria, hypertension, edema, and oliguria. Please learn. Now I will tell you the reasons for them. Let me draw a diagram of the kidney. You know, in excretory system in the humans, it is a pair of kidney. You can see these are the kidneys, these are the ureters, this is the urinary bladder, this is the urethra I am trying to draw, and here I am drawing the aorta. From the aorta I am drawing these renal arteries. Now here the kidneys are damaged. The kidneys are damaged. You know, inside the kidney there is a nephron. Inside the kidney, the nephron is the structural and functional unit of the kidney. We know that in one kidney there are 1 million nephrons. So in nephron there are 5 parts: glomerulus containing the Bowman's capsule, PCT, loop of Henle, DCT, and collecting duct, right? So you can see this is the nephron. Now in each of these kidney 1 million nephrons are present. So humans have nearly 2 million of nephrons. Right, now these kidneys are damaged due to certain diseases. The kidneys are damaged. So basically the glomerulus inside that is damaged in various types of glomerulonephritis. Inside the kidney, inside the nephron, the glomerulus is damaged. Now whenever the glomerulus is damaged, normally when the blood is filtered through the glomerulus, when the blood is filtered, glomerular filtration rate, so blood and protein do not come in the urine. So normal patient, normal person, healthy human being have no blood and no protein in the urine, because in the glomerulus blood and protein is not filtered. But here the kidneys are damaged, so they are filtering. I mean to say the glomerulus is damaged, so they are filtering the blood also, the protein also. So RBC and protein both coming in the urine. So that's why patient have hematuria, patient have proteinuria, number 1 thing, right? Now what is the function of the kidney? Why God has provided a pair of kidney? What is the function? Of course, everyone know kidney is an excretory organ, so the kidney is required for excretion. Now imagine if the kidneys are non-functional. If the kidneys are non-functional, so sodium and water will not be excreted. Normally kidneys excrete sodium and water. So sodium water will not be excreted because both the kidneys are not functional. So sodium and water retention will be there. In the blood there is sodium water retention. Because of sodium and water retention, the person have hypertension. More sodium in the blood, more water in the blood. That is the reason for the hypertension. More sodium water retention also leads to edema. Whenever there is more water in the body, there is edema in the body. That leads to edema. And since the kidneys are damaged, urine output will be less. That is the reason for oliguria. So in this one diagram, I taught you the cause of all 5 things. What are the 5 things? Can anyone help me in summarizing the 5 things? Number 1, hematuria. Number 2, proteinuria. Number 3, hypertension. Number 4, edema. And number 5, oliguria. I hope you got it. Right, give me a thumbs up if you got it. So these are the 5 features of the nephritic syndrome. Mind my words, I'm teaching you nephritic. We will soon come on nephrotic, right? So the same thing is given in front of you. Just a second. Hematuria. Because of the hematuria, urine is smoky in appearance. 𝗷𝗵𝗃 casts are present in urine. Proteinuria is there. Proteinuria is although mild, non-selective, but it's there. Hypertension is there. You know the reason. Edema is there. The reason is sodium water retention, and oliguria is there. Got it? Got it? Say yes, everyone. Give me a thumbs up. You got it? Now coming on the examples of nephritic syndrome. What are the examples of nephritic syndrome? So among the glomerulonephritis, you have to learn at least 5 examples. Most important, it's post-streptococcal glomerulonephritis. That is our question right now, which we are discussing. So post-streptococcal glomerulonephritis is an example of nephritic syndrome. Rapidly progressive glomerulonephritis, membrana proliferative glomerulonephritis, focal and diffuse proliferative glomerulonephritis, and IgA nephropathy is both nephritic nephrotic. So please learn these examples. Among them, the most common is RPG, and it's also a PYQ. The most common cause of nephritic syndrome, most common is among them is RPGN. So that's all about the nephritic. Now coming on the nephrotic, the most common is RPGN. Never forget. Coming on the nephrotic syndrome. Now what is nephrotic syndrome? In nephrotic syndrome, if any patient coming to the doctor with the 6 complaint, these 6 complaint, we will say that patient is having nephrotic syndrome. Here there is no hematuria, there is no blood in the urine, right? So you will get a negative finding in the question, no RBC cast. So that is, the examiner is pointing you towards the nephrotic syndrome. Okay, there is no hematuria, no blood in urine, but proteinuria is there. So proteinuria is a common feature in both. But the difference is that in nephritic syndrome, proteinuria was mild, and in nephrotic syndrome, the proteinuria is massive. The proteinuria is massive. Okay, now most of the protein from the blood is lost in urine because there is massive proteinuria. Come on. So in the blood, hardly any protein is left. So that is known as hypoalbuminemia. Albumin is the protein, main protein. Hypoalbuminemia. Because most of the protein is excreted in urine. That's why in blood it's less. Uremia is urine, anemia is blood, you know. So proteinuria, that's why hypoalbuminemia. Now most of the protein is lost in urine, that's why in blood there is less protein, less albumin, right? So it will lead to edema. Now what is, so edema is again common feature in nephritic, nephrotic, but what is the cause of edema here? Here the cause of the edema is hypoalbuminemia. You may be knowing there are two types of pressure in the blood. There are two types of pressure in the blood. This is a blood vessel. Have you heard about Starling's law in physiology? So there are two types of pressure, hydrostatic pressure and osmotic or oncotic pressure. The hydrostatic pressure, as the name indicates, hydrostatic pressure is due to water and it's always outward. And osmotic pressure is due to the protein that is present in blood. The protein is the albumin we are talking. Okay, albumin is the main protein. Okay, we are talking about that. So that is always inward pressure. Now I am saying that in the disease that is nephrotic syndrome, massive proteinuria is there. So most of the protein present in the blood, most of the albumin is lost in urine. It is lost in urine. So in the blood, hardly any protein is there. Hardly, just give me a 1 minute. Okay. I'm sorry. So hardly any protein, hardly any albumin. So that leads to decreased oncotic pressure. Because the oncotic pressure is less, so inward pressure is less and outward is more, and that will lead to edema. This imbalance will lead to edema. So here also I agree edema is there, but the cause of edema is different. Please understand. Very important PYQ. Now you get 2 PYQs in your exam. What is the cause of edema in nephritic syndrome? Answer is sodium water retention. What is the cause of edema in nephrotic syndrome? Answer is hypoalbuminemia leading to reduced osmotic pressure. And in both of these questions, both of these options will be there. So don't get confused. Your concepts should be crystal clear. You got my point? So that is the reason for edema. That is hypoalbuminemia as a reason for edema. I will draw the diagram for this also. Apart from that, there is hyperlipidemia and hyperlipiduria. I will explain you why. This means that lipid increase in the blood as well as in urine. Lipid is increasing in the blood as well as urine. You may be thinking, ma'am, what is lipid ka kya lena dena? What is the role of lipid here? I will explain. Don't worry. And last is hypercoagulability. The blood become hypercoagulable and multiple thrombus are formed. Let me draw the diagram and explain you all these 6 findings one by one, why they happen. If you understand the reason why they happen, you will never forget. So you can see here I am drawing a pair of kidneys, I am drawing the ureter, I am drawing the urinary bladder and the urethra. Okay, you can see. And here I am drawing the aorta from which these renal arteries are coming. You can see these renal arteries are coming, going inside the kidney. Now here also kidney is damaged. The kidney is damaged. Kidney is such damage that most of the protein is lost in urine, not blood. Not blood, but protein is lost. It's too much. It is massive. I'm using the word massive and I'm insisting the word massive. There is massive proteinuria. Since most of the protein is lost in urine, so how much is left in the blood? In the blood, hardly any protein is left. That is known as hypoalbuminemia. Albuminemia. So first thing is massive proteinuria. Second thing is hypoalbuminemia. Okay. Now less protein in the blood will lead to edema because of less oncotic pressure. Less oncotic pressure, that will lead to edema. So this is the cause of edema, the third finding. Now such a massive loss. What is the source of protein in human body? In human body, we get protein from 2 things. Number 1, diet. Whatever we eat, it absorbs from the intestine. And number 2, it is synthesized in the liver. Now, because most of the protein is lost in urine, so liver will try to compensate it and try to increase the synthesis. You got my point? Liver try, body always try to compensate the things. So liver try to compensate the lost protein. So when liver try to compensate the lost protein, instead of forming protein, the liver is forming lipoprotein. Lipoprotein is a protein only. So liver तो भला करने की कोशिश कर रहा है. Liver is trying to compensate by making lipoprotein. लेकिन उसे भला नहीं हो रहा है, उससे और बुरा हो रहा है. You got my point? So liver is making lipoprotein. So more lipoprotein, more lipid absorption. Lipoproteins are what? They are VLDL, LDL, chylomicrons. They are more. So more lipid absorption. So more lipid in the blood. This is the reason for more lipid. More lipid in the blood, that will be excreted in the urine. So this is the reason for more lipid in urine. So first there is more lipid in the blood, then more lipid in the urine. This is the reason of hyperlipidemia and hyperlipiduria. Okay, so this is the 4th finding. This is the 5th finding. You can understand with numbering. Okay, and the last one is that I told you from the blood all the proteins are lost. There is massive proteinuria. So one of the protein is antithrombin. Antithrombin is a protein. Antithrombin protein is present in human blood and that prevents thrombosis. Antithrombin, it prevents thrombosis. But during massive proteinuria, it is also lost. Along with albumin, it is also lost. Now there is no antithrombin, so blood will become hypercoagulable. And this is the reason for last thing, the 6th thing, hypercoagulability is the loss of antithrombin. Now tell me the 6 findings. If you have learned the reason now, you can get multiple questions on that. that, and you should know the 6 in a row. 1, 2, 3, 4, 5, 6. What are the 6 findings? This is all about nephrotic syndrome. Can you please write down what are the 6 findings? Yes. Number 1, it's massive proteinuria. Say the word massive, which will lead to hypoalbuminemia, less albumin in the blood, which will lead to decreased oncotic pressure leading to edema. The third finding. Okay. Now, because of the massive proteinuria, liver try to compensate. Liver is making more lipoprotein. Instead of protein, it is making more lipoprotein. So that is leading to hyperlipidemia, more lipid in the blood, and most of the lipid had lost in urine. So hyperlipiduria. One of the protein is antithrombin, that is also lost in urine, and that will lead to hypercoagulability. So these are the 6 findings of nephrotic syndrome in front of you. You got the reason. So same thing is written in front of you. I'm skipping the theory. I already explained you. What's the reason of heavy proteinuria? It will lead to hypoalbuminemia. It will lead to edema. The cause of the edema is reduced osmotic pressure, not sodium water retention. The next is hyperlipidemia. The cause of hyperlipidemia is liver, which is trying to compensate the heavy protein loss. And instead of making protein, it is making lipoprotein. So more lipoprotein, more lipid, hyperlipidemia. More lipid in the blood is lost in urine, that will lead to lipiduria, hyperlipiduria. And last is hypercoagulability. The reason for that is loss of antithrombin 3. I want all of you to give me a thumbs up if you got it. So what are the examples? Giving the examples, and then I will do a comparative analysis between the two. So what are the examples of nephrotic syndrome? The examples are minimal change disease. Okay, minimal change disease. The second example is membranous glomerulonephritis, not membranoproliferative. Membranoproliferative comes in both examples. Membranoproliferative will come in both examples. Okay, and these are the common examples in both. The exclusive examples, you have to learn this one and this one and this one. Okay, it's minimal change disease, membranous, and focal segmental glomerulosclerosis. I'm sorry, not nephritis. Okay, let me write. So what we have learned, let me summarize it quickly. Okay, who will help me? Let me summarize it very quickly. We have learned 2 syndrome, nephritic, nephrotic. Okay, so here in nephritic, you have to tell me 1, 2, 3, 4, 5 symptoms, the cluster of 5 symptoms. In nephrotic, you have to tell me 6 symptoms. So first finish this, then we will come on the examples. Okay, so here in nephritic, the patient have hematuria, the patient have proteinuria. Okay, hematuria is blood in urine, proteinuria is protein in urine. The third is hypertension, that is increased BP. The next is edema, and the last one is oliguria. Okay, these are the 5 symptoms. Please learn, you know the reason. You can draw a diagram and tell me the reasons. Coming on nephrotic syndrome. In nephrotic syndrome, there is no hematuria. It is a specific finding of nephritic. So in your question, if you are getting RBC in urine, it has to be nephritic, one of the nephritic. It can't be nephrotic. Rule out the options of nephrotic. Okay, so here there is proteinuria. On nephrotic syndrome, there is proteinuria, but here the proteinuria is mild and here the proteinuria is massive. That is the difference. Okay, here the proteinuria is non-selective. That is almost all proteins are lost, but in little quantity. Here it's almost selective. Most of the protein lost is albumin. That is the meaning of selectivity. Okay, now since most of the albumin is lost in urine, so in the blood there is less albumin. That will lead to hypoalbuminemia. In the blood, there is less albumin. That will lead to reduced oncotic pressure. That will lead to edema. Now see, edema we have here also and edema we have here also, but the reason is different. Here the reason of edema is sodium and water retention, very important PYQ, and here the reason of edema is reduced oncotic pressure, very important PYQ. Please mind it and learn it. After that, liver try to compensate. So more lipid in the blood, more lipid in the urine because of lipoprotein synthesis. Hyperlipidemia, hyperlipiduria, and last is hypercoagulability of the blood because of loss of antithrombin. Please learn it. Okay, now coming on the examples. Tell me the examples. So exclusive examples, let me tell you. Here it's what is the most common example of nephritic syndrome? Okay, it's RPGN. First of all, it's RPGN, then PSGN. Learn these two are specific this side. Okay, and here we are coming, it's the most common, you can say, it's MCD, that is minimal change disease in the children, and in adults it can be membranous glomerulonephritis and focal segmental glomerulosclerosis. These are specific this side. Apart from that, few common examples in which sometime nephrotic and both can occur. So what are those? It can be IgA nephropathy, it can be membranoproliferative glomerulonephritis. These are the examples. So that's all about it. Give me a thumbs up. Do you all got it? Can we go ahead? Yes, so that is nephritic versus nephrotic, and definitely you will get, most of the time question is asked from this topic. I cannot say which question, but you frequently get question. You can get no, most common also. Okay, let me tell you, the most common cause of nephritic syndrome is RPGN. Most common cause of nephrotic syndrome, it's different in children and different in adults. So if they ask in children, so answer is MCD, that is minimal change disease. If they ask in adults, so answer is focal segmental glomerulonephrosis. FSGS. So that is the thing. Here children and adult, it's same, it is RPGN. So nephritic most common cause is RPGN. Nephrotic most common cause, there are two. In children it's MCD, in adults it's FSGS. So this is all about that. So learn the symptoms, learn the reason, learn the concept behind that, learn the example, learn the most common. We are done. Coming on the next question, next topic. Okay, so the next question is in front of you. Are you people there? Kindly be interactive. If you have any doubt, please write down. Otherwise, please indicate that you got it. Give me a thumbs up. Okay. The next question is in front of you. In this way, we are not going to cover question. We are going to cover topics. So that topic will become perfect. Very good. Very good. So antecedent diagnosis of group A streptococcal infection in acute rheumatic fever can be made by antecedent. What do you mean by antecedent? Antecedent means past. In the past. Okay. Antecedent diagnosis of group A streptococcal infection in acute rheumatic fever can be made by. The options are ASO titer, that is anti-streptolysin O titer, CRP, C-reactive protein, ESR is elevated, low C3 levels, or what is it? Can you tell me the answer? Okay. Definitely after the class, the PDF will be provided to you on the Arise Telegram group only, and you can contact the Arise team. They will definitely provide you the PDF for that. I will share it with the team, and they will put it on the YouTube only. They will pin that. Okay, you can get the notes from there on this YouTube channel only where you are watching it. So can we go ahead? Can we go ahead? Okay, what is the correct answer? The correct answer is the ASO. Okay, I will come on the question again. Let me explain. So the question is about rheumatic fever. So let's start the next topic, rheumatic fever. I will tell you everything about rheumatic fever. Most frequently question is asked from this topic. Okay, what is rheumatic fever? Most of the students even don't know rheumatic fever hota kya hai. What is rheumatic fever? Which organ disease it is? It is a multi-organ disease. Listen, I'm telling you a story of the rheumatic fever. Imagine there is a child. You know, rheumatic fever occurs in children. That's why I'm saying, imagine this is a child. The child is having tonsillitis. Tonsillitis is very common in child. You may also have multiple episodes of tonsillitis when you were a kid, you know. So tonsillitis, the child is having a tonsillitis. What is the most common bacteria which cause tonsillitis? We all know the most common bacteria which cause tonsillitis or pharyngitis is group A beta streptococcus bacteria. It is known as gas. Group A streptococcus. Gas, group A beta streptococcus bacteria. So you will say, ma'am, what is the problem then? So what body is forming antibodies against the bacteria? The antibody is going binding with the antigen, that is the bacteria. Antigen antibody complexes are formed and they are phagocytosed, they are removed from the body. You will say, then ma'am, what is the problem? How does rheumatic fever is related to here? Let me come on the point. Bacteria do not cause rheumatic fever. No, bacteria is gone, bacteria is dead. What is the problem is that on the surface of the bacteria, few antigens are present. Antigens are epitopes. The same antigen are present on human 5 organ. Which 5 organ? The heart, number 1, you can see. Number 2 is brain. These are the 2 vital organs, heart and brain. Number 3 is skin. Below the skin, it's subcutaneous tissue. So 3 is skin. Below the skin, it's subcutaneous tissue. And below that, we have joints. So learn like that. Heart, brain, skin, subcutaneous tissue and joints. So these 5 organs are there on which, you know, on the surface of the bacteria, M protein is present. The name of the antigen is M protein. The similar M protein is present in the 5 human organs. That is the problem. So actually the antibodies are formed against the bacteria. Okay, but these antibodies will get confused. Antibody will think this is also bacteria. So they will also form antigen antibody complexes in these 5 organs, the M protein of these 5 organs. Okay, they get confused. This is known as cross reactivity. This theory is known as molecular mimicry and cross reactivity. What I am saying? Molecular mimicry. What do you mean by mimicry? Mimicry and nakal utarna. So who is doing mimicry of whom? So bacteria is doing mimicry of the human 5 organs. So human 5 organs have M protein, bacteria also have M protein. So who is doing the cross reactivity? So antibodies are formed against the bacteria, but they cross react with the human 5 organs and damage the human 5 organs, causing 5 diseases in 5 organs. What are the name of 5 diseases? In heart, there is rheumatic heart disease. Okay, in the brain, it's chorea, known as Sindam's chorea. In the skin, there is a rash in the skin. It is known as erythema marginatum. Just below the skin, subcutaneous tissue have multiple small painless nodules. So that is subcutaneous nodules. And in the joints, there is arthritis. Inflammation of the joint. It is polyarthritis. Multiple joints are involved in sequence. It is migratory. It migrates from joint to joint. Migratory polyarthritis. The 5 diseases together known as rheumatic fever. So rheumatic fever is not single system disease. It is a 5 diseases together. The 5. So it's an umbrella term. Rheumatic fever means 5 diseases together. Which 5 diseases? They are in front of you. So in the heart, in the brain, in the skin, in the subcutaneous tissue, in the joints. So can I say who is causing these 5 diseases? Is it bacteria who is coming and causing? No. In all these 5 organs, bacteria is absent. Come on. These are the antibodies. They are killing body's own. They are damaging body's own cells, own organs. That's why these antibodies are known as autoantibodies. What these are known as? What these are known as? Yes, these are known as autoantibodies because they are damaging body's own. So there is a Jones criteria. Revised Jones criteria are there for the diagnosis of rheumatic fever. Imagine you are a pediatrician and a mother is coming carrying the child to you. Doctor, my child is having certain symptoms, and if you are examining the child is having multiple system involvement, and you are having high suspicion that this child is having rheumatic fever because multiple systems are involved. It's a multi-organ disease. You can see the five systems are involved here. So what you will do? You will apply Jones criteria. What are the Jones criteria? There are 5 major criteria, 4 minor criteria, and 3 supportive criteria known as gas criteria. Gas is the bacteria. So that is. So what are the 5 major criteria? The 5 major criteria are the 5 diseases only. You know, I told you the 5 diseases. In the heart, it's carditis. In the joint, it's arthritis. In the brain, it's chorea. In the skin, it's erythema marginatum. In the subcutaneous tissue, it's subcutaneous nodules. So the 5 diseases are the 5 major criteria. Okay, what about minor criteria? Whenever we have tonsillitis, we have fever also. So fever is a minor criteria. Now, please mind my words. Arthritis is a major criteria. Arthralgia is minor. What do you mean by that? Arthritis. Itis का मतलब होता है inflammation. So inflammation of the joint is major. Or algia. Algia means pain. Pain in the joint is minor. Whenever the person have inflammation, there is pain also. But inflammation is major. Pain is minor. Arthritis, arthralgia. Due to the carditis, PR interval on ECG will increase. Heart is involved now. The walls of the heart will involve, and on ECG, PQRST, PR interval will increase. ESR and CRP will also increase because it's an infection. So these are the 4 minor criteria, right? Now imagine I'm a pediatrician and a child is coming to me and having multiple. So the child is having most of the major criteria, most of the minor criteria. So the first question I will ask the mother, do the child have tonsillitis few days back, few weeks back? And mother is saying no, the child don't have tonsillitis. So still, would you like to classify it as a rheumatic fever? Would you like to make the diagnosis of rheumatic fever? The answer is no. We cannot make the diagnosis of rheumatic fever unless until the tonsillitis is proven. After the tonsillitis, the major minor should be there. If directly you are saying major minor, without tonsillitis, it cannot be rheumatic fever, because without tonsillitis, it should not happen. I agree the bacteria is not causing it, but without bacteria, autoantibodies will not form. And autoantibodies are causing the disease. You got my point? So sometimes what happens is the tonsillitis is very mild. It is subtle. So patient can miss it. The mother can miss it. The parents can miss it. Okay. So we have to do certain tests for that. That is known as supportive criteria for the gas infection. Group A streptococcus infection. You are getting it? So how you will prove that? Imagine I'm in clinic and there is a child in front of me. So I heard the child is having murmurs, so heart is involved. The child is having involuntary movements in the air, that is chorea is there, brain is involved. The child is having rash, the child is having nodules in the subcutaneous, the child is having bone joint pain. So most of the major criteria is there, minor criteria is there, but gas criteria, how should I prove that this is all after streptococcal infection? The mother is saying no, child don't complain of tonsillitis. So what to do? So you have to test that, right? That is supportive criteria. How we can test the streptococcal infection? Take a swab, like ask the child to say ah, and take the swab and try to culture on a culture plate. If you find the growth of streptococcus, it's positive. So that is the culture. Throat swab culture. Okay, number 1. Number 2, look for the antibodies in the blood. 2 types of antibodies which are autoantibodies, and these antibodies are actually causing the damage in the 5 organs. So what is the name of those antibodies? It is anti-streptolysin O antibody, ASO titer, anti-streptolysin O antibody, and anti-DNase antibody. So that is the gas criteria. So what we have learned? We have learned the Jones criteria. These are the revised Jones criteria. The revision is done in 2016. Okay. So 5 major criteria. Okay. 4 minor criteria. Okay. And 3 supportive criteria. Who will tell me? The 5 major. Who will tell me? The 4 minor. And who will tell me? The 3 supportive. Let's try together. Okay, the 5 major are the 5 diseases. What are the 5 diseases? The major diseases. In the heart, it's carditis. In the brain, it's 𝗬𝗲𝗃𝗃. In the joints, it's arthritis, polyarthritis. And in the skin, it's subcutaneous. In the skin, it's erythema marginatum. In subcutaneous tissue, it's nodules. So please learn. It's very easy. In the minor criteria, patient have fever. Okay. Arthritis is major, but arthralgia is minor. Whenever the heart is involved, there is increased PR interval. That is minor. And increased ESR, increased CRP is also minor. Coming on the supportive criteria, in the supportive criteria, number 1, throat swab culture. Do a throat swab and try to culture it. Okay. After that, you can do the antibody. 2 types of antibody you have to look in the blood of that child. Number 1, ASO antibody, anti-streptolysin O titer, and number 2, anti-DNase antibody. That's all about it. Now let's come on the question. Now you will try the question and you will get your answer. Have a look on the question, please. What is the question here? Antecedent diagnosis. Antecedent diagnosis of group A streptococcal infection in acute rheumatic fever can be. What do you mean by antecedent? So in the past, the patient have group A streptococcal infection, and after that the patient have acute rheumatic fever. That is, they are asking for the supportive criteria. So is it ASO titer? Is it CRP? Is it ESR or low C3 level? So I guess everyone know the correct answer is ASO. CRP and ESR are raised, but these are minor criteria, not supportive to be specific. So correct answer is A. Okay, got it. You got it. Divya, others, Divyanshi, Binita, Soumya, everyone give me a thumbs up. Can we go ahead? The next question is in front of you. Please read it. Try it. Most characteristic finding in diabetic nephropathy. What is the most characteristic finding in diabetic nephropathy? Yes. What is the most characteristic finding? Is it Kimmelston-Wilson kidney? Is it diffuse glomerulosclerosis? Is it focal segmental glomerulosclerosis or Armani-Ipston lesion? So what is the correct answer? Can you please try it out? Can you please try it out? Yes, the correct answer is Kimmelston-Wilson kidney, that is KW kidney. Don't worry, I will come on the question again. Let me explain you the next topic today. The next and third topic which I am going to teach you in detail is diabetic nephropathy. So let's start diabetic nephropathy. So what is diabetic nephropathy? You tell me, what is diabetes mellitus? Diabetes mellitus is a disease in which patient presents with hyperglycemia. The glucose level in the blood is elevated. It is of 2 types, type 1 and type 2. But in both of them, the common feature is that the patient have high glucose level in the blood. You will say, ma'am, how does it matter? If the glucose level is more, will it cause some damage? Yes. Ideally, it should get controlled with the help of anti-hypoglycemic drugs, or with the help of insulin. If the patient is controlling the glucose, the sugar, it's okay. If the patient is not taking the treatment, the increased glucose which is present in the blood, that will cause damage to 3 human organs. Which are the 3 human organs? Number 1, retina of the eye. Okay. Number 2, the nerves, the peripheral nerves. And number 3, the kidneys. Number 3, the kidneys. So this is known as diabetic retinopathy. This is known as diabetic neuropathy. And this is known as diabetic nephropathy. So my topic of choice, current question, it's diabetic nephropathy. So that is an orientation what I am teaching you. Now I am teaching you diabetic nephropathy, which is a complication of diabetes. So if the diabetes not get treated for years, it is not very acute complication, it's a chronic complication. If the hyperglycemia is remain in the blood for 5, 10, 20 years, then the kidneys are damaged. It is not one day. It is not acute, it is chronic complication. Okay, so that is the meaning of diabetic nephropathy. You got my point? Diabetic nephropathy. So in diabetic nephropathy, how does, at microscopic level, how does the kidney is involved? So in the glomerulus, 2 things are there. You can see inside the glomerulus, there are 2 things. Diffuse glomerulonephrosis, nodular glomerulonephrosis. There are 2 types of presentation. I will explain you both one by one. First, I will let you know what is diffuse. Then I will let you know what is nodular. So let's start with the diffuse. Diffuse is more common. This is the diagram. Can you see the diagram? Can you understand what is shown in the diagram? Let me explain you. If it is pink and purple for you, let me make easy for you. Listen. Can you see this is a glomerulus? See, this is glomerulus. Can you all see? This is glomerulus. But this is not normal glomerulus. Now here, because the glucose level in the blood is more from years and years and patient has not treated it, so hyaline deposition occurs in the glomerulus. Hyaline. Hyaline is deposited here at 4 places. See the 4 places. Number 1, it is deposited in the mesangium. Can you see pink color hyaline? This is pink hyaline is there. It is known as mesangial matrix. What is hyaline? It is a structureless pink color eosinophilic acellular material. It is getting deposited in the mesangial matrix, number 1. Number 2, it is deposited in the basement membrane of the capillaries. Can you see these are the capillaries? See the basement membrane, it's very thick. It's pink deposition is there. The capillary's basement membrane, that is known as thickened glomerular basement membrane. Number 2. Number 3, it is deposited in the form of a cap of the capillary. Can you see this capillary have worn a cap like this? It is looking like a pink cap. It is looking like a pink cap. Here also a pink cap. It is known as fibrin cap. Okay. And number 4, it is present in the Bowman's capsule. Where is the Bowman's capsule? You can see in the Bowman's capsule this pink deposit, this pink deposit. So it is diffuse. I highlight and insist the word diffuse. I highlight and insist the word diffuse. What do you mean by diffuse? It is deposited at 4 places. You know, you can see the 4 places there. So it is there diffuse. So that is the meaning of the diffuse. Diffuse glomerulonephrosis. So hyaline is deposited at 4 places. So which 4 places? GBM, mesangial matrix, Bowman's capsule, and the cap of the capillary. That's why known as diffuse, and this one is more common. The second one is nodular. So this one is not more common, but it is more specific. It is pathognomatic, most specific, most characteristic. And it is also known as KW kidney. Here also hyaline is deposited. Here also, can you see the glomerulus here also? Here also hyaline is deposited. It is not everywhere at 4 places. It is at 1 place only. Which is that place? It is in the form of the nodules. Can you see a nodule? Pink color nodule, a circular nodule, oval nodule, here, 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 here. So that's why it's known as nodular. So hyaline is deposited there also, here also. See both of them back to back. Let me compare. Fatafat, everyone here. So see, diffuse glomerulosclerosis, nodular glomerulosclerosis. The first thing you have to learn, this is more common, and you have to learn this is more specific. The more specific is the pathognomatic and characteristic. So please mind your question very carefully. Whether they are asking more common, answer is diffuse. And if they are asking more specific, that is our question right now. More specific or more characteristic, answer is nodular. There is one more name of nodular, that is Kimmelston-Wilson kidney. Diffuse don't have any other name. In both of them, one feature is common, hyaline get deposited. But it is where deposited? Now as the name indicate, in diffuse, it is diffuse. Diffuse means at 4 places. And in nodular, it is in the form of nodules. So in diffuse, it is in the mesangium, it is in the Bowman's capsule. Here is the Bowman's capsule. It is in the capillary walls, and it is in the cap of the capillary. So these are the 4 places. That's why it's diffuse. And in nodular, it is in the form of the nodules. You can see the pink color nodules. So that's all about it. Now have a look on the question and read the question and tell me the answer. So most characteristic finding in diabetic nephropathy. What they are asking, most characteristic. Characteristic means specific, means characteristic, and pathognomatic. So is it Kimmelston-Wilson kidney or diffuse glomerulosclerosis? I agree both happen, but here the characteristics say. Okay, if I change the question from most characteristic to most common, would you like to change your answer or still continue with the same? Would you like to change your answer if I change the question a little bit? Instead of characteristic, if I ask you most common, the most common finding in diabetic nephropathy, would you like to change the answer? In that case, answer will become B. Okay, you all got it. In that case, the answer will become B. Can we go ahead? Can we go ahead? Give me a thumbs up. Are you enjoying the session? Right. Before coming to the next session, let me tell you something. There is a very good proverb, strive for progress, not for perfection. It's a very small proverb, but the meaning is very big. Let me explain you. I will take just 30 seconds. Okay, I will not waste your time. I have seen most of the students, they start with a subject, or in a particular subject they start with a particular topic, and they keep on reading that subject or that particular topic till they become satisfied with that, 100% perfect in that. So they study it from one platform. If they have some doubt, it's difficult topic, difficult subject, they used to see same from another platform, another topic, another app, another book, another source. By doing so, what they are doing, they are becoming 100% in some subject, some topics, but the time is limited. Now at the end you will realize you have not even touched some subjects and some topic, and that is the worst strategy you are following for your exam preparation, whatever exam you are targeting. If you are targeting FMGE, NEET PG, next, you know, for university exam, whatever. So this is the biggest mistake most of the students I have noticed they are doing. Don't do that. Don't do the perfection. Don't follow the even average. Instead of 100%, if you are doing 90% or 80% of every topic, the most important for that is a smart work. You have to do smart work, not the hard work. Instead of perfection, try for progress. So always keep on progressing. You just make target that I am having today's 24 hours. Today in the morning I am starting my study. I will study for 8 hours, 10 hours, whatever, and this much portion I will study. So whatever you can cover in that, the best, the next day with the next schedule. You should not continue the previous one. I hope you are getting my point, and most of you have experienced this problem what I am talking about. So strive for progress, not for perfection. Coming on the next question is in front of you. Most sensitive indicator of iron deficiency anemia. The question is from hematology. They are asking most sensitive Indicator of iron deficiency anemia. Is it ferritin? Is it TIBC? What is TIBC? Total iron binding capacity. Is it percentage saturation of transferrin or is it bone marrow iron? Many students even don't know bhai TIBC hota kya hai? What is TIBC? They even don't know the full form, and if they know the full form, they don't understand the meaning of that. They don't understand what is percentage transferrin saturation. They don't know what is ferritin. So how could you answer anything about iron deficiency anemia? So it's time to perfect. Yes, the correct answer is ferritin. You all are right. But if I twist the question, you will get confused. So let me help you with the next topic in detail. Iron deficiency anemia. We will see the detail and the important points just in 3-4 minutes. So let's start iron deficiency anemia. There is a master diagram in front of you. Okay. So I have drawn this diagram, the sketch diagram. Let me explain you. This is the digestive tract of a healthy human being. So whatever iron we eat in our diet, it can be vegetarian iron, it can be non-vegetarian iron. The vegetarian iron is present in spinach, green leafy vegetables, jaggery, gur, and in the non-vegetarian iron is present in meat, red meat, you know. So whatever iron we eat, it is in ferric form, Fe3 positive, the first thing. Okay, that is going in the mouth, that is going in the esophagus, that is going in the stomach, that is going in the intestine. You can see this is intestine. In the intestine, you can see the cell of the intestine. Let me highlight the cell of the intestine to explain you the mechanism. So you can see this is one of the intestinal cell, that is enterocyte, behind which the blood vessel is present. So what I want the iron to get absorbed into this cell and go into the blood. For that, 2 transporters are required for the cell. One on the luminal side and one that will absorb the iron from the lumen to the cell, and the other on the basolateral side that will take the iron from the cell to the blood. You got my point? So 2 transporters are required. The name of the first transporter, the luminal transporter, it is known as DMT, divalent metal transporter. And the name of the transporter which is present on the basolateral side, it is known as ferroportin. What it is known as? Ferroportin. You got my point? So this is the thing, these 2. But see, what is the luminal? The luminal, towards the luminal side, what is the transporter? Say the name. It's DMT. What is the full form? Divalent. Divalent means it will absorb Fe2 positive, not Fe3 positive. So the problem is that whatever we are eating is Fe3 positive, but the intestine is saying I will absorb Fe2 positive. So before coming in the intestine, iron has to be converted from Fe3 to Fe2. I mean to say from ferric to ferrous, ferric to ferrous. Okay, Fe3 to Fe2. This job is done by HCl. HCl present in the stomach, hydrochloric acid, that convert Fe3 positive to Fe. So take first concept, more is the acid, more is the absorption. Any acid, it can be hydrochloric acid, it can be amino acid, it can be ascorbic acid present in the citrus fruits. Okay, so any acid increase the absorption of iron because it helps in conversion of ferric to ferrous. More ferrous, more absorption. So here it will get absorbed from here to here. From inside the cell, it tries to go in the blood. So the second transporter will help. The second transporter is ferroportin. So that will take the iron out in the blood. Ferroportin will take it. Okay. So while doing so, ferroportin again oxidizes it from Fe2 positive to Fe3 positive. So ultimately in the blood it's Fe3 positive. So my point is that whatever we eat is Fe3 positive, whatever reaches the blood is Fe3 positive. But only for absorption purpose it's Fe2 positive. Okay, ferric ferrous funda, the first funda on which many questions are asked and you get confused. Number 2, now coming on the second story. Listen, after reaching in the blood, iron don't walk. Iron need a scooter on which it will walk, the vehicle of the iron, the transporter of the iron. The name of that transporter is transferrin. Can you see? This is transferrin. Transferrin. Transferrin is the transporter of iron. T for T. Transporter of iron is transferrin. Learn that. On one scooter, 2 iron will sit. So one transferrin carries 2 molecules of iron. Please learn that. I have drawn 1, you can make 2 to 2. Okay, so it's also a PYQ. One transferrin carries 2 molecules of iron. Now where the iron is required in human body? From head to toe, where it is required? Iron is required in human body only for one function, for heme synthesis, for heme of hemoglobin synthesis. And where is heme synthesized, hemoglobin synthesized? I mean inside the RBC. So where is RBC synthesized? So RBC is synthesized inside the bone marrow. So basically iron is required in the bone marrow. Why in the bone marrow? Because in the bone marrow the RBCs are synthesized that require iron for hemoglobin synthesis, to be specific. So the transferrin will take it to the bone marrow. Okay, take it. Whosoever wanted, take it. So all the precursors of the RBC take the iron for their hemoglobin synthesis, but they will take that only how much they required. Now after that, if any extra iron is there, the transferrin will take it to the liver, and iron is stored in the liver. Extra iron, I insist the word extra. Extra iron is stored in the liver in the form of the ferritin. So next important PYQ in your exam is ferritin. Ferritin is storage form of iron. Storage, more ferritin means more storage. Okay, Transporter of iron is transferrin, it's also a PYQ. Storage of iron is ferritin, it's also a PYQ. Don't get confused between transferrin and ferritin. Transferrin T for T, transporter is transferrin and storage is ferritin. Okay, so this was the story, the complete story. Now imagine there is this is my digestive system, and from today I stop eating iron due to any reason. Maybe the person is sick, maybe the person is poor, maybe the dentation is not there, maybe the person is old, maybe any reason, maybe due to some religious reason the patient is not eating food, patient is on fasting. So what will happen? The subject, not the patient. What will happen? You tell me. So from today only I will have iron deficiency anemia. I don't eat iron in the diet. So this complete iron I'm not eating, it is not reaching to the bone marrow. You will say, no ma'am, you have the backup. The backup is the ferritin. So ferritin will give iron to the bone marrow. Normally bone marrow get iron from the transferrin coming from the blood, the intestinal iron which is absorbed. But if you are not eating, no worries now. The backup is there. Backup is the storage. Storage is the ferritin. So liver start releasing the iron to the bone marrow. Don't worry, I will give you iron. You continue synthesizing hemoglobin. So for the next 2-3 months, whatever is there, the backup is there. Patient don't have iron deficiency anemia. A point will come when ferritin also becomes 0. Ferritin also becomes 0. At that point, the patient will synthesize less hemoglobin. So less hemoglobin, smaller RBCs, patient have microcytic hypochromic anemia. So then the patient have frank symptoms of anemia. But initially, so before the hemoglobin drop, ferritin is dropping. You got my point? You got the reason. Now you got the answer. That's why ferritin is more sensitive indicator as compared to hemoglobin. Say yes if you got it. Everyone say yes if you got it. You got my point? So ferritin is falling first. First ferritin fall, becomes 0. After that hemoglobin fall. So which is a better indicator for iron deficiency anemia judgment? Which is the most sensitive? Which is the earliest? Answer of all of this is ferritin. If I ask you most sensitive, answer is ferritin. If I ask you earliest, answer is ferritin. If I ask you best indicator, answer is ferritin. The reason is in front of you. Say yes, come on, interact, don't be silent. Got it? So that is the funda. Now let me explain you 2 more concepts here. बात निकली ही है तो complete करते हैं TIBC और transferrin saturation. Students may have confusion in that. Can you see here the blood vessel inside which the iron is sitting on the scooter? The scooter of the iron, the transporter of the iron is transferrin. Let me draw it on the next page. So this is a blood vessel of a healthy individual in which this is the scooter I am talking about. The transferrin, the transporter of the iron. I told you on 1 to 2 molecules of iron are there. So one transferrin carry 2 molecule of iron. You got that. Okay. Now, normally in a person, say 100%. Total 100 transferrin are present. Total 100 scooters are there. Imagine, out of which how many are saturated, how many are filled at a time. Healthy individual I'm talking about myself. So at a time only 33% are occupied. And the remaining 66% are empty. They are empty. 66. This is normal in everyone. It's like that. So the filled one are 33 and the empty one are, in terms of percentage, the empty one are almost 66. This is out of 100%. The 100 scooters we are talking, the transferrin. Okay. The filled one are known as saturation. It's known as transferrin saturation. You can understand they are saturated, ma'am. That's why they are transferrin saturation. It's known as. Okay. The empty one are known as TIBC. TIBC kya hai? Now you got it. What is TIBC? The empty one. What is the full form of TIBC? Now you say you will get it. It's transferrin iron binding capacity. You say na ki mere mein aur itni capacity hai. I have capacity matlab we can do it more. Right? This is the empty one. So this is our capacity. More we can acquire. So this is TIBC. So transferrin saturation are the filled one and TIBC are the empty one. Now you tell, this is healthy. This is healthy in a healthy model. But what happened in iron deficiency anemia? What happened? Now you tell me what happened in iron deficiency anemia to this and what happened in iron deficiency anemia to this. Common sense. In iron deficiency anemia, you will say, ma'am, there is less iron. Iron deficiency anemia matlab iron kam hai. There is less iron. Less iron, to jo bhara hua hai, the filled one will be less and the empty one will be more. So transferrin saturation will be less and TIBC will be more. Give me a thumbs up. So in iron deficiency anemia, tell me the findings. You will say, ma'am, the first and earliest finding, ferritin will be fall, the best indicator. After that, hemoglobin will also fall, right? And during this, the empty one are more and the filled one are less. The filled transporters are less. That is, transferrin saturation will be less, but TIBC will be high. This is the reason why TIBC will be high. Most of the students don't understand, ma'am, TIBC high kyun hai? This is fall, this is fall, this is fall. Why TIBC is high? Very frequently asked question. You got the concept today. So you get many questions on that. And iron deficiency anemia is a microcytic hypochromic anemia. I guess everyone know that. No need to tell. Okay. Okay, so let's proceed. So that is about the iron. You can see. Okay, one more concept here in this slide. Iron deficiency anemia is microcytic hypochromic anemia. How many types of anemia are there morphologically? Let's say the classification of the anemia. Morphologically, anemias are of 3 types. Normocytic. Okay, let me tell you one more thing. Okay, before coming on the classification of anemia, let me tell you something. Size and color. We have to see 2 things in RBC: the size of the RBC and color of the RBC. Color is given by the hemoglobin. Size in size is known as cytic. In pathology, size matlab cytic. In pathology language, the color means chromic. Chroma का मतलब होता है color. See the dictionary meaning of chroma. Chroma means color. So chromic. Cytic means size. Chromic means color. Okay, cytic means size, chromic means color. Okay, so let me tell you normal RBC. This is a normal RBC. What is the size? What is the color? Let me tell you. The size of a normal healthy RBC is 7.5 micrometer. It is the diameter. Please, it's normal. It's always like that. Okay, this is the normal size. And what about the color? RBCs are non-nucleated cells. They don't have nucleus. They have in the periphery, they have the hemoglobin. So hemoglobin provides a pink color. So hemoglobin is present at the peripheral 2/3. I repeat my words. Hemoglobin is present at the peripheral 2/3. So peripheral 2/3 is colored. It is colored always. And central 1/3. Central 1/3 is empty. It's known as pellar. This is the normal color distribution. So normal size, normal color. You have seen normal size, you have seen normal color. Now let me tell you the classification of anemia which I was telling you. So based on size, RBC are of 3 types. And based on color, RBC are of 2 types. Based on size मतलब size का क्या मतलब है? Size मतलब cytic. We call size as cytic and we call color as chromic मतलब color. Okay. So based on size, RBCs are of 3 types. Normocytic are the normal size. Microcytic means they are less than 7.5 micrometer diameter, and macrocytic means they are more than 7.5 micrometer. These are normal size, these are small, these are large. The cutoff is 7.5 micrometer. Smaller than that, bigger than that. Normal is 7.5 micrometer diameter. Based on the color, normochromic. The first is the normochromic. See the suffix. Mind the suffix. Normochromic means normal color. By normal color, I always mean that peripheral 2/3 is color and central 1/3 is empty. I mean that. And the second is hypochromic. Hypo means less. Don't use the word micro. Here we are using micro. Here use the word hypochromic. What do you mean by hypochromic? Now use your brains and tell me what is less color. Less color. So periphery less than 2/3 is color and central more than 1/3 is empty. So I'm drawing 2 RBCs in front of you. See this RBC, see this RBC. The size is same, but here I'm drawing central 1/3 is pellar, peripheral 2/3 is colored, approx. But here I'm drawing hardly any color at the periphery. So peripheral less than 2/3 is colored and central 1/3 pellar elaborate, it increases, expand I mean. So this RBC is hypochromic, this one is normochromic. You got it? So this is the meaning. Now listen, let me classify anemia. Again and again I am saying the first type of anemia is normocytic normochromic. So RBC is normal size, normal color, still patient is anemic. The first type of anemia, normocytic normochromic. The second type is microcytic hypochromic. RBCs are smaller, color is also less. This anemia is known as microcytic hypochromic. And third type of anemia, macrocytic. But we don't have the term hyperchromic. The chroma can decrease, color can decrease, but color cannot increase. Never. There is no terminology. Hyperchromic नाम का कुछ term ही नहीं है दुनिया में. There is no word like that. So macrocytic will form a bond with normochromic. So macrocytic RBCs are bigger in size but normal color. So what are the 3 types of anemia? Normocytic normochromic, microcytic hypochromic, macrocytic normochromic. So these are the 3 types of anemia. I hope you got it. So based on size, based on color, we classify the anemias are of 3 types. Size matlab cytic, color matlab chromic. So normocytic normochromic, microcytic hypochromic, macrocytic normochromic. Give me a thumbs up. So that is the classification of anemia. Can we go ahead? So that is the thing. So the same thing is written, I told you, in anemia. So coming on the next question now. The next question is rolling of WBC on endothelial cell is mediated by. Rolling of WBC on endothelial cell is mediated by what? Can you tell me the answer? The 4 options are in front of you. Is it selectin? Is it integrin? Is it transferrin? Is it PCAM? What is the correct answer? Yes, the correct answer is the selectin. I will come on the question again. Let me explain you the complete mechanism. What does the rolling mean? From where we are talking about? We are talking about the acute inflammation. What is acute inflammation? In acute inflammation, there are 2 types of events, the vascular events and the cellular events. It's an ultra important topic. In acute inflammation, there are 2 events. The vascular events are there, few vascular events and cellular events. So what do you mean by that? Let me explain you this diagram. Can you see a blood vessel here? Of course, you all can see a blood vessel. Can you see a microbe here? Can you see this is a microbe? Microbe can be it can be bacteria, it can be virus, it can be fungus, it can be parasite. And inside the blood vessel, we can see the WBCs. The WBCs is the defense mechanism. Let me explain you like this. To microbe, I will tell you like a story. The microbe we call a terrorist. The terrorist is the foreign body. No, who's terrorist? Anything foreign in the country who cause harm to the country people. That is terrorist. So microbe is like that. So call the microbe as terrorist. And who is the army? I will call the WBC as army. The army defends us. So that is our army, right? So whenever any terrorist enters in country territory, what happens? The army get activated and there is a fight between the terrorist and army, and let's see who is more stronger. So the same thing is happening in human body. In the human body, as soon as any microbe is entering, the army get activated, they want to fight. You will say, ma'am, then why they are not fighting? What is the problem? The problem is that the microbe, the terrorist, it's extravascular outside the blood vessel, and the army, that is WBC, of course it's intravascular. So how they meet? If they don't meet, how they fight? So you will say, ma'am, let's meet them. Let's make them meet. So how to meet? So there are two possibilities. Either take microbe inside. No. It's a bad idea. If you take the microbe inside the blood vessel, sepsis will occur. The microbe will spread to all the organs. No, we cannot do that. We cannot afford that. The other way around, take the WBC out. Yes, we will do that. Take the WBC out. So we will try to take the WBC out. But there are 6 steps in that. These are known as cellular events. You got my point? There are 6 events. There are 6. So taking WBC out is not an easy job. We have to do it step by step. First of all, we have to increase the permeability of this blood vessel. In the blood vessel, these are the endothelial cells. See, these are the endothelial cells. They are continuous with each other. So first we have to create a gap that is known as endothelial gap from which this WBC will come out. So the endothelial gap is created. The first step, we have to create this endothelial gap. So there is an endothelial gap from which this WBC will come out. So you will say, okay ma'am, endothelial gap is already created. We can see. Now take the WBC out. Again, it's not an easy job because WBC are present at the center of the blood vessel. Have you read Bernoullis Theorem in physics? What does the Bernoullis Theorem say? Bernoullis Theorem say that in a pipe, whenever any fluid travel in a pipe, the heavy portion goes at the center and the lighter portion goes, at the periphery. Now let's consider the blood vessel is a pipe. Blood vessel is a pipe. In the blood vessel, we have 4 things: RBC, WBC, platelet and plasma. Who is the heaviest? Unfortunately, heaviest is the WBC. So WBC are at the center. Okay. And after that, there are RBCs are there. Lightest is the platelet. You can see these are the platelets, and most lightest is the plasma. So at the periphery there is plasma. This is the distribution. So I agree there is a gap. The gap is there. But if the WBC was at periphery, it was easy to take it out. But WBC is at the center. It cannot jump out of the gap, So first you have to take the WBC to the periphery. So we will do it step by step. You got my concern? You got my problem? Keep interacting. Give me a thumbs up. Got it? So what are the 6 steps? Now with this overview, you will understand the 6 steps. Okay, listen, can you see here? I'm showing you the 6 steps. Just a second, give me a minute. So first thing, you have to take the WBC out. Let me show you. You can see here, I'm drawing the WBC. This is the WBC at the center. Everyone see? Everyone see the WBC is at the center. Can you see the WBC at the center? So first step, you have to take the WBC to the periphery so that we can take it out. This step is known as margination. What it is known as? Read. Margination, because we are taking the WBC to the margin. This step is known as margination, right? Now here is the gap. Where is the gap? The gap is little bit ahead. Here is the gap. You can see this is the gap. So gap is little bit ahead. It is not we are taking it to the margin at the same place there is a gap so it will jump it out. No, it is not like that. Gap thoda sa aage hai. Okay, it is little bit ahead. So how does the WBC will go there? So WBC will roll like a tire on a road. I repeat, it will roll like a tire on the road. Who is the tire? Who is the road? I am saying the tire is the WBC. You can see this is a tire. And who is the road? The road is the endothelium. So the WBC will roll like a tire on the road. The tire is the WBC and the road is the endothelium. This is known as rolling. That is our question right now. Our question is on rolling. Most of the students don't know ki rolling hota kahan hai. So rolling is taking place in the blood vessel in which the tire is rolling on the road. You know what is tire, what is road, right? So this step is known as rolling. I will tell you the details how does it occur. Okay. After that, the gap is there. Before the gap, it has to stop. It cannot roll always. It has to stop before the gap. So the third step is adhesion. The first step was margination. WBC leave the center and come to the periphery. This is known as margination. After that, it roll. Okay, that is known as rolling, like a tire on a road. Just before the gap, it stop. Stoppage is known as adhesion. Now the time it will come out. From intravascular to extravascular, the most important step known as either transmigration or diapediasis. Better to say it as diapediasis. So the fourth step is diapediasis. So WBC leave the blood vessel and come out. That is diapediasis. After that, WBC don't have eyes. Where is the terrorist? Where is the microbe? I will go and kill it. WBC. So it is a three-dimensional space. So WBC is coming out in a 3D space. Now in a 3D space, where does the WBC will go? Where is the microbe? Here is the microbe. So what does the microbe do? Microbe will secrete certain chemicals from it. The bacteria will secrete certain chemicals that will attract the WBC. Ki yahan hu main, aaja. Hai na? It is giving the signal. So the movement is chemical oriented, chemical gradient oriented. This is known as chemotaxis. So the fifth step is chemotaxis, in which WBC will move towards the bacteria through a chemical gradient, right? Ultimately, it will do phagocytosis of the bacteria, engulfment of the bacteria, kill the bacteria. So this is the story. So close your eyes and tell me the 6 steps. What are the 6 steps? First is margination, in which WBC leave the center and come at the periphery. After that, rolling, in which WBC roll on the surface of the endothelial cell like a tire on a road. After that, adhesion, it will stop just before the gap. After that, diapediasis. Diapediasis means it will come out. It will come out from intravascular to extravascular. After that, chemotaxis. Chemotaxis means chemical oriented movement. And the last one is the phagocytosis. Phagocytosis. Ultimately, the WBC will do the engulfment of the microbe. Say yes. Everyone got it? Now here I am interested in the step rolling and adhesion in detail, because that is my question. I cannot teach you all 6 steps. The most important step, rolling. How does rolling and adhesion take place? How does rolling and adhesion take place? WBC don't have legs like it is walking or it is rolling. So everything in pathology takes place with the help of receptor. So there are receptors on the present on the surface of the WBC. The corresponding receptors are present on the endothelium. So they form bond, the bond is broken. The transient bonds are formed. You got my point? So transient bonds. The word to be picked here is the transient bond. See this diagram. Can you see this diagram? In this diagram, can you see the blood vessel? In the blood vessel, can you see the red color endothelial cells here? See the lower part. See these endothelial cells I am marking for you. And see the WBC. Everyone have a look on the WBC. These are the WBCs I have drawn to you, right? So can you see the receptor pairs? These are the pairs. Can you see the first pair, second pair, third pair, fourth pair, fifth pair, and the last 6th pair? So there are 6 pairs. You cannot interchange them. I will tell you the name of the 6 pairs, in which molecule is present on the WBC, which molecule is present on the endothelium. They form a pair with each other, which helps in rolling. So this bond formed, it is broken. Again, the next bond is formed, it is broken. In this way, the tire rolls on the road. The tire rolls on the road with the help of receptor. So first a bond is formed, broken, then again it moves. Bond formed, broken, then again it moves. In this way, rolling takes place. And just before the gap, the bonds are stronger. So it is known as adhesion. It is known as adhesion. You got it? So this is rolling and adhesion. So basically you have to learn the 6 pairs. 6 pairs. What is the name of these 6 pairs? 6 pairs are in front of you. You have to learn which molecule is present on the road, that is endothelium, and which molecule is present on the tire. The tire is the WBC. So there are selectins, P-selectin and E-selectin. They are present on the road. The selectins are present on the endothelium. They form bond with 𝗲𝗏. Our answer is selectin right now. Okay, so this is our answer we are discussing. Okay, you can see. So P and E-selectin form bond with 𝗲𝗏. They form bond with 𝗲𝗏. Number 1. The third type of selectin, L-selectin, is present on the WBC. L for leukocyte. You learn like that. L for leukocyte, it is present on WBC. It form a bond with glycam. After glycam, you should learn ICAM and VCAM. They form bond with integrin. And finally, PCAM form bond with PCAM. So you have to learn. I know the terminologies are a little bit difficult. The name of the proteins and molecules receptors is a little bit difficult. But you get many questions on them. Please believe me. So please learn the 6 pairs. They are in front of you. See how beautifully I have drawn them. Can you see it? So please say the names. So you can see the first is P-selectin and E-selectin present on the endothelium. They form bond, both of them, 𝗲𝗏. The third selectin is present on the WBC. That form a bond with glycam. Glycam से याद आएगा ICAM और VCAM, जो bond बनाएंगे integrin के साथ, beta-2 and beta-1 integrin. And last, the ultra important is PCAM with PCAM. So only one molecule which forms bond with itself only, PCAM. PCAM is also known as CD31, and this one is important for transmigration. So it's an ultra important PYQ. Everyone give me a thumbs up. Please learn the 6 pairs. These are the couples. You cannot change the partners. These are the couples. You cannot change the partners. Learn the 6 couples, 6 pairs. I mean, you cannot interchange. So P-selectin and E-selectin, both of them form bonds with silyl-Lewis sites. Glycam form bonds with L-selectin. You cannot do the interchange. No, you have to learn specifically which one is forming bond. Now have a look on your question and you can get the answer. Can I come to the next topic? Okay. The next question is in front of you. Stellate-shaped granuloma is seen in. Can you tell me the answer? Stellate-shaped granuloma. What is stellate-shaped granuloma? Is it seen in sarcoidosis? Is it seen in cat scratch disease? Is it seen in Crohn's disease? Is it seen in TB, tuberculosis? Where does it seen? What is the correct answer? Yes. Can anyone tell me what is the correct answer? The correct answer is the cat scratch. Okay, I will tell you why it is the correct answer. So what is stellate shaped? Stellate ka matlab hota hai star. What is star shaped? Star is like this. Let me draw a beautiful star for you. So sometimes, I'm sorry, the granuloma looks like this. This is stellate shaped granuloma. Stellate means star shaped granuloma. It is seen in cat scratch disease. So for understanding, it's a variant of granuloma. First you have to understand the normal granuloma. How does a normal granuloma is formed? If you don't understand what is normal granuloma, how you will understand the stellate granuloma? So let me first tell you normal granuloma. What is the composition of granuloma and pathogenesis? How does it form? You are interested? Shall I tell you? You get many questions on granuloma. Okay. So shall I tell you how granuloma is formed? Whenever any non-degradable antigen enters in human body, I say the non-degradable antigen like the Mycobacterium tuberculosis, Mycobacterium leprae, there are many organisms, talcum powder, है ना? So whenever any non-degradable antigen enters in human body, so what happens? The first cell which come in contact with it is antigen presenting cell. The antigen presenting cell will engulf this antigen, try to degrade this antigen but unable to do so. I repeat, the antigen presenting cell will engulf the antigen, try to degrade the antigen but unable to do so because it is a non-degradable antigen. So antigen presenting cell will be very tense. Oh my god, what should I do now? I am unable to degrade it. So it will go to helper T cells. It will go to the next cell. The next cell is the helper Th1 cell. So it will ask what to do with this antigen. It is non-degradable. I am unable to degrade and process it. So helper Th1 cell, don't worry, I will secrete 3 cytokines from me. So 3 cytokines are secreted. You have to learn the name of these 3 cytokines which are secreted by helper Th1 cell in case whenever any non-degradable antigen enters in human body. What are these 3 cytokines? It is interferon gamma, number 1. Interleukin 1 and 2, number 2, and TNF alpha, number 3. Please learn it. You have to learn. There is no escape. Please learn. Interferon gamma. Okay, just a second. Interferon gamma, interleukin 1 and 2, and TNF alpha. Okay, these are the 3 cytokines which are secreted. What they do? What does actually these cytokines do? They all take one cell from the blood out of the blood in the tissue. Wherever this all is taking place, in that tissue they will take out. So what is the name of that cell? What cell they are taking out? Let me tell you one by one. Let's talk about interferon gamma. Interferon gamma takes monocyte out. You know, in blood we have one of the WBC, it is known as monocyte. So once the monocyte out of the blood, it is no more monocyte, now it is known as macrophage. So basically they take the monocyte out and convert them into macrophage. Not only this, they modify the macrophage. By modification I mean they increase the cytoplasm, the nucleus will become vesicular, enlarge. A modified macrophage is known as epithelioid cell. Epithelioid because they look like epithelium but not epithelium. Epithelioid cell. So basically interferon gamma take the monocyte out, convert them into macrophage, modify the macrophage and make them epithelioid. Right, here also one nucleus, here also one nucleus. Multiple epithelioid cells fuse with each other and they form giant cell. So interferon gamma is doing 3 jobs. They are in front of you. They form macrophage, they modify macrophage into epithelioid cell, fuse epithelioid cell with each other and form giant cell. This is number 1. Let's talk about the second interleukin 1 and 2, the second cytokine. What does they take out? They take out T lymphocytes, T cells. T lymphocytes are also present in blood. They take that out, migrate them and proliferate them. So T lymphocytes will get collect here. These are the T lymphocytes. And what about the third one? The third cytokine, that is TNF alpha. What does they take out? They take the fibroblast out. In the blood we have fibroblast, the spindle shaped fibroblast which synthesize the collagen. So they take that out and cause the migration and proliferation of the fibrocytes there. So fibrocytes are there. So we have at the end we have 3 types of cell. What are the 3 types of cells at the end we are having? We have actually 4. Epithelioid cells and giant cell. I am considering them as 1 because giant cell are the fusion version of the epithelioid. Number 1. Number 2, T lymphocyte. Number 3, fibroblast. They will rearrange themselves and they form a granuloma. So at the center of the granuloma, just a second, we have epithelioid and giant cell. The middle zone of the granuloma is formed by T lymphocyte and the periphery of the granuloma is formed by TNF-alpha. Okay, so let me draw a beautiful granuloma for you. Then I will show you the variant of the granuloma. So you can see at the center I am drawing the epithelioid cells. These all are epithelioid cells. Some of them fuses with each other and they form the giant cell. So I am drawing some giant cells also. You can see I am drawing some giant cells. So this is the center. Okay. Just surrounding it, the middle zone is the T lymphocyte. You can see I'm drawing the T lymphocyte. And the most periphery is the fibroblast. The fibroblast, what does they do? They synthesize collagen. And what does the collagen do? Fibrosis. So outer to this is the fibrosis. You can make it out. Okay. Now you can see the center, the epithelioid cells and giant cells are due to interferon gamma. Very important IBQ, very important PYQ in your exam, interferon gamma. The middle zone is the T lymphocyte, which is due to interleukin 1 and 2. And outermost fibroblasts are due to TNF-alpha. This is a granuloma, a typical granuloma. In some granuloma, the center have caseous necrosis. The center may have. So there are two types of granuloma. The hard, which don't have caseous necrosis at the center, hard tubercle, and the soft tubercle, they have caseous necrosis at the center. This is a typical diagram of a granuloma. Now you got it. How does it form? What is the pathogenesis? What is the mechanism? Which cells are involved? Which cytokines are involved? They are in front of you. And what is the structure? Say yes. You got it? First give me a thumbs up if you got it. Then I will tell you one of the variant, that is stellate granuloma. The same diagram is in front of you, which I have explained you. You can see the central blue color cells. These all are epithelioid cell. You can make out one of the giant cell also. So these are epithelioid cell and giant cell. You can see the middle zone. The middle zone is the red color cells. The red color cells are the lymphocytes. And outermost you can see the spindle cells with the fibrosis. Spindle cells with the fibrosis, that is fibroblast. Okay, can we go ahead? Can we go ahead? Are you people with me? So one of the variant of the granuloma is known as stellate. I told you the meaning of the stellate. The meaning of the stellate is star-shaped. So sometimes it's a variant of granuloma. Here, normally granuloma don't have neutrophil. I told you three types of cells: epithelioid cell, T lymphocyte, and fibroblast. It don't have neutrophil. Normal granuloma don't have neutrophil. Here, neutrophil is present. Here, neutrophils is present. A collection of neutrophil. It's an exception, right? So here, the shape of the granuloma is star. Make it out. You see, it's like a star. I have marked, I have highlighted. Okay, it's like star-shaped granuloma. Okay, and it is seen in two diseases. Please learn the name of the diseases at the tip of your tongue: cat scratch disease and LGV, that is lymphogranuloma venerum. Cat scratch disease and lymphogranuloma venerum, these are the two diseases in which star-shaped granuloma is seen. Can you see? So now read the question and tell me the answer. Stellate granuloma is seen in which disease? So among the option from LGV and cat scratch is present. So we will go with that. If LGV is also present, now we can mark that also. Say yes. Can we go on the next topic? Don't just understand the question, understand the topic. Now I'm explaining you one question, but behind one question I'm explaining you 20 questions. It is not only one question I'm explaining. In one question, 10-20 questions are hidden. I'm explaining you the complete thing. So very frequently these topics are asked in your exam. Okay. So instead of giving you more number of questions, it's the more of knowledge and completion of the topic is important. Okay. So let's come on the next question in front of you. Okay. All are true about apoptosis except. Read the option. Inflammation is present. Is it true or false? Chromosomal breakage. Is it true or false? Clumping of chromatin. Is it true or false? And cell shrinkage. What is the correct answer? What? No. C is not the correct answer. Capricorn. What is the correct answer? Inflammation is never present in apoptosis. Let me tell you. Now there are two types of cell death. What are the two types of cell death? Let's talk about cell death. Okay. Let's talk about cell death. There are two types of cell death: apoptosis and necrosis. Okay, apoptosis and necrosis. These are the two types of cell death in front of you. You will say, ma'am, why cell death? I mean, why there are two different mechanisms of cell death. Apoptosis is like suicide. Yes, it's like suicide. And necrosis, I call it a murder. So in both of them, the person die, but the mechanism is different. In the same way, in both of them, the cell die, but the mechanism will be different. Why I am saying apoptosis is like suicide, I will tell you the reason. And why I am saying necrosis is like murder, I will tell you the reason. Just understand there are two types of cell death. Currently, we are talking about apoptosis. In apoptosis, 7 things happens one by one in a cell. Please see the 6 things happen one by one. So these are the 6 morphological changes occurs. So see, this is a normal cell. You see, start with normal cell. Please see, I have drawn a beautiful sketch diagram for you to show you the process step by step taking place in apoptosis, the murder. The first thing in a normal cell, you can see cell shrinkage. The first thing is the shrinkage. The earliest feature of apoptosis is cell shrinkage. It's an important PYQ, ultra important PYQ, repeated many times. Cell shrinkage. So cell reduces in size. So there is a normal cell which reduces in size, that is cell shrinkage. Now, whenever these are the cell organelles present, it can be mitochondria, ribosome, endoplasmic reticulum, many cell organelles are present. Whenever the cell is doing shrinkage, the cell organelles, they got clustering. They got clustering in a small space. That's why the cytoplasm look more pink. This is the reason. The second finding is the eosinophilia. What is eosinophilia? Eosinophilia is pinkishness of the cytoplasm. Just a second. It is pinkishness of the cytoplasm. The cytoplasm become pink in color because the cell organelles get clustered. Second finding is eosinophilia. Okay, first is cell shrinkage, second is eosinophilia. After that come on the nucleus of the cell. See the nucleus here. The nucleus become more compact, okay. The compact nucleus is known as pycnosis. Condensation of the nucleus is known as pycnosis. After that, look at the nucleus. Nucleus get fragmented into pieces. It gets fragmented into multiple pieces. It is known as karyoraxis. What it is known as? Karyoraxis. Okay, so pycnosis, karyoraxis I will consider in one. Both are nuclear findings. So first is cell shrinkage, then there is eosinophilia, then there is pycnosis and karyoraxis. Right, now see the cell surface. See the cell surface. The surface of the cell, multiple blabs are formed. Can you see? These are the blabs. The cytoplasmic blabs are formed. So on the surface of the cell, multiple blabs are formed, but mind my words, during blab formation, the cell membrane is intact. There is no defect in that. It is not the case that during blab formation there is a rupture or no rupture, no defect. It's intact. Mind the word intact and highlight it. The blabs are formed. Now the blabs will separate, taking a small portion of nucleus with that. Nucleus is already fragmented. They will take small nucleus with them and they form multiple small bodies. All the blabs separate from themselves, from each other. It is known as apoptotic bodies formation. What does it mean? Apoptotic bodies are formed. During the entire process, there is no leakage. I repeat, there is no leakage because the cell membrane is intact. There is complete intact cell membrane, and they just take small portion of nucleus, they separate. Small portion of nucleus, separate. They all separate from each other. During the entire process, there is no leakage, and in the end, can you see a green cell here? A phagocyte come and engulf all of them. In the end, a phagocyte is coming and engulfing all of them. This is known as phagocytosis. So there is no leakage, so that's why there is no inflammation. If there is no leakage, the WBC don't come to know that something wrong is happening. Neutrophils will not come and there is no inflammation. No leakage and no inflammation differentiate apoptosis from necrosis. In necrosis, inflammation and leakage is always present. In necrosis, here in apoptosis, the cell is shrinking. No? In necrosis, the cell increase in size. Here cell decrease in size, their cell increase in size. Here by shrinking, it is forming blabs and apoptotic bodies. There in necrosis, it increase and burst. So here there is no leakage. They are in bursting, leakage is there. That's why here no inflammation and their inflammation is there. Got it? Say yes. So that is the main. So what are the karyolysis? Muhammad Imran, karyolysis don't take place in apoptosis. Karyolysis is basophilia of the nucleus, but that don't take place in apoptosis. That takes place in necrosis. Okay, you got it? Got it? So what are the 6 features? First tell me of apoptosis. The first thing is the cell shrinkage. I told you 6 features. The first is the cell shrinkage. Okay, the first finding. After that, the cell organelles come closer. That will lead to pinkishness of the cytoplasm. That is known as eosinophilia. Okay, after that come on the nucleus feature, pycnosis and karyoraxis, not karyolysis. Okay, the fourth finding after that, blabs are formed. After that, the blabs separate from each other. That is, apoptotic bodies are formed. But there is no leakage. I repeat, no leakage, no inflammation. You have to write here. No leakage and no inflammation. Okay, these are important findings. And lastly, phagocytosis take place. So it's like this is all about apoptosis. Now let me differentiate apoptosis and necrosis. I told you apoptosis is suicide and necrosis is murder. I will tell you the reason now. Listen. Apoptosis takes place of a single cell. Necrosis takes place of a group of cell. Now, whenever a person is doing suicide, it's alone. No, it is not the complete village is doing the suicide. The complete city is doing. No, but murder can be done of multiple people at a time. Okay, so that's why apoptosis is suicide because of single cell is dying at a time. Necrosis, there are more reasons. Here the cell is shrinking. Here the cell is swelling. Right? Here only pycnosis, karyoraxis, and Imran mind it. Karyolysis, karyoraxis, and pycnosis, karyoraxis, and karyolysis is a finding of necrosis, but not apoptosis. The first 2 are common in both. Okay, the most important here, the cell membrane is intact, so no leakage, inflammation absent. Here cell membrane disrupt, the cell burst out because cell is swelling, bursting out. So the leakage is present and inflammation is also present. The most important feature which differentiate apoptosis from necrosis. Let me tell you, whenever a person is doing suicide, it is in silence now. The person will not take a mic and announce everywhere I am doing suicide. It is in personal, it is silence. And chup chap. That's why it's like that. No leakage, no inflammation. Nobody come to know okay, he's doing suicide. In the same way, nobody come to know in the body this cell is undergoing apoptosis. It's silence. It's silence. No leakage, no inflammation, cell membrane intact, cell is shrinking, chup chap se wo shrink ho jayega and disappear. So the person who is doing suicide slowly decrease and disappear. It's like that, and single cell. So now you will not forget. And here multiple cells are there. Now whenever person is murdered, the person will shout. All the persons together will shout, help, help, help. So they are shouting. Shouting means this plasma membrane rupture and leakage is present. So everyone is coming for the help. So inflammation is present, neutrophils are present. Now compare apoptosis with suicide and necrosis with murder. You will never forget the differences. Apoptosis and necrosis, the two type of cell death, suicide versus murder. This is single cell at a time, this is multiple cell at a time, right? Here the cell shrink, that is decrease in size. The cell shrink and here the cells swell. Okay, here no leakage, so no inflammation. Here leakage present, inflammation present. The most important findings I can quote like that. Give me a thumbs up, you got it. Now have a look here. Have a look here and tell me the answer. What you are asking, 𝗵𝗏𝗍, chromatin clumping is also seen in irreversible injury. Definitely, 𝗵𝗏𝗍, by the way, irreversible injury, 𝗵𝗏𝗍, it is the other name given to the cell death. And I am teaching you cell death only. So these are the synonyms. Irreversible cell injury is the cell death only. So cell death is apoptosis and necrosis. You got it? So you are very correct. But these two are synonyms. So you are talking about the same phenomenon. Okay. So read the question. All of the following are true about apoptosis except. Now tell me the answer. Inflammation is present? No. Inflammation is never present in apoptosis. It's silence. It's suicide. Okay. Chromosomal breakage. By chromosomal breakage, they mean karyoraxis. Fragmentation of the nucleus is chromosome breakage. So karyoraxis is present. Yes, Hannah. So this is right. Clumping of chromatin, they are talking about pycnosis. Yes, pycnosis means clumping, condensation. So yes, this is also present. And cell shrinkage, yes, it is also right. Cell shrink, it's suicide. It will disappear. So the other three findings are right, but inflammation never present in apoptosis. It is present in necrosis. I hope you got it. Okay. Yes, everyone. All those who are watching me live, give me a thumbs up. Can we go ahead to the next question? So you got many questions in this difference table. You get many questions on apoptosis, necrosis, which is right, which is wrong, or conceptual question. Once you have understood now, you will not forget now. Always remember inflammation, apoptosis is like suicide and necrosis is like murder. Coming on the next question in front of you. All are true about arterial thrombosis except. The next question is on the arterial thrombosis. All of the following are true about arterial thrombosis except. Read the options. Retrograde growth, line of Zahan, wide thrombus and complete lumen obstruction. What is incorrect among them? Can you tell me the answer? Yes, the correct answer is D. I will come on the question again in the end. Don't worry. Let me teach you thrombosis. What is thrombosis? Okay. Let me come on the topic. Bhai, hota kya hai thrombus? What is a thrombus? Students even don't understand from the basic. Ma'am, what is thrombus? We even don't know that. Okay, let's start from zero. Imagine I have a cut here. What will happen? Of course, I bleed. Everyone bleed if we have an injury anywhere on the body. Okay, but what happens next? So you will say, ma'am, you will bleed for the next few seconds, maybe few minutes. After that, bleeding stop automatically. Why bleeding stop automatically? Why? In all of us it happens. Bleeding stop automatically. This mechanism by which bleeding stop automatically, it is known as hemostasis. As the name indicates, hemo matlab blood and stasis means stop. So stoppage of bleeding is hemostasis. It's a physiological phenomenon. It's not a disease. It's a physiological useful phenomenon given by the God, by which, imagine if there is no hemostasis, God has not given us the hemostasis. We have a small cut, we continue to bleed, there is no stoppage and all 5 liters of the blood is lost in the bleeding and patient die. But thankfully this doesn't happen because God is great and God has given us a physiological mechanism in our body that is known as hemostasis, in which at the site of the bleeding, whenever there is an injury, there is a defect, there is a cut in the integrity of the blood vessel, that gets sealed automatically with the help of clot formation. So clot is formed and the sealing is happened. I mean to say this is a blood vessel. In the blood vessel, this is a defect. Can you see? In the wall of the blood vessel, I am drawing the endothelial lining. So there is a defect in the endothelial lining. This is the defect. So bleeding takes place from here, bleeding. But immediately, as soon as there is a defect, the platelet will come. The platelet will form a primary clot here that will further stabilized by the fibrin. Fibrin will make a meshwork over it. उसके ऊपर धागे जैसा बन जाएगा रस्सी के जैसा और इसको stable बना देगा. So first a primary clot is formed by platelet and secondarily it is stabilized by the fibrin like a thread over that. Okay, so this clot is formed. So there is integrity. Now bleeding will stop. Thankfully bleeding will stop. Within few minutes it happens and bleeding is stopped completely. This is hemostasis. Is it useful for us? You will say, ma'am, what a rubbish question. Of course it is useful for us. So whenever there is a defect, the clot formation is useful. Okay, the clot formation is useful. Now let me ask you a question. Imagine there is no injury. No injury. Without injury, if clot is formed, there is no injury. The same clot, the primary clot is made up of platelet and secondarily it is stabilized by the fibrin threading. Fibrin is making a meshwork, I mean. So without injury, the only difference, there is no injury. Is it good? You will say, no ma'am, why it is forming? It is interrupting the flow of the blood vessel. This blood vessel may be supplying some organ. All blood vessels supply to some organ. This is an organ. It may be an artery, it may be a vein. So it is causing obstruction in the flow of the blood vessel. The organ may have ischemia if it is an artery and the organ may have congestion if it is a vein. Okay, so it is not useful. It's a disease. It is known as thrombus. So thrombus is same as that of hemostasis. The only difference in hemostasis, there is a defect in the blood vessel, there is an injury. So after injury, the clot is formed. It's hemostasis, and without injury, if the clot is formed, the same clot, the same mechanism, the same composition, it's known as thrombus. So first give me a thumbs up that you got the meaning of that. You got the meaning of that. Okay. So yes, so that is the meaning of the thrombus. It's a disease. So you have to differentiate hemostasis from thrombus. Now thrombus are of two types. Of course, whether it is present in artery or vein. So arterial thrombus and venous thrombus. See, I have drawn a diagram for you. Can you see in this diagram? Everyone appreciate this is an artery. I am highlighting with red color. See the flow of the blood. You can see the organ in the middle. So artery is carrying blood towards the organ. That's why this is an artery. And this is a vein. I'm drawing the vein with blue color. See, it is having impure blood. So it is, see the arrow. It is carrying blood away from the organ. You can see you can see thrombus in both of them. Now thrombus can form in the artery. Thrombus can form in the vein. So there are two types of thrombus: the arterial thrombus, the venous thrombus. This diagram is a master diagram depicting the differences between the two. Master diagram. See here. So one by one we will see. Come on the arterial thrombus. Arterial thrombus. Now you can see intentionally I have drawn it yellow color and intentionally I have drawn the venous one the red color. Intentionally I have chosen these colors because arterial thrombus is white in color. White I cannot use, that's why I have used yellow. White or pale because it is having more platelet inside that. More platelet giving white color, more fibrin giving white color. It is known as white thrombus. On the contrary, the venous one is red in color because it is having more RBCs inside that, the composition wise. So arterial one are white or pale and the venous one are red. The first difference. Learn the differences. Number two, the arterial one is incompletely obstructing the lumen. You can see a space, still a space is left, but the venous one is through and through obstructing, through and through. So that's why the arterial one are mural. Mural means incomplete obstruction, and the venous one are occlusive. Occlusive means complete obstruction. So this one is incomplete obstruction. This one is complete obstruction. Learn the word mural and occlusive. Got it? Got it? The third difference. Okay, we have seen two differences. The third difference. In arterial one, the lines of Zahan are present. In venous one, the lines of Zahan are absent. You will say, ma'am, what are lines of Zahan? Matlab kya hai na? In the arterial one, can you see inside the yellow? I have drawn light, dark, light, dark, light, dark, light, dark, light, dark lines are there. In the venous one, no such lines are there. These light, dark, light, dark, light, dark lines are not there. So what is this light, dark? The light is the platelet. I'm sorry, the light is the platelet, the dark is the RBC, the light is the platelet. So it's like platelet RBC, the alternate layers are there. But in venous one it's compact, mainly RBC, hardly any platelet. So that's why lines of Zahan are present here, that is alternate light dark bands, but lines of Zahan are absent in venous. Please learn that. Now the fourth is common sense. The fourth difference is common sense. You don't have to learn that. Imagine there is obstruction in the artery. So what will happen to the organ? What will happen? Artery carry pure blood to the organ. Now there is an obstruction, so organ will not get the pure blood. It will not get the pure blood. That's why organ will have ischemia. So the end result of arterial thrombosis is ischemia. Obviously, venous carry the impure blood away of the organ. Veins carry venous impure blood away of the organ. Now if there is an obstruction in the vein, impure blood will not go away. It will accumulate in the organ. That will lead to edema and congestion. So that is the end result. That is the effect of the thrombus. Arterial thrombus leads to ischemia. Venous thrombus leads to edema. That I mean to say. Say yes, everyone. Yes. Okay. Can we go ahead? The fifth and the last difference. The fifth. Four I have already depicted in front of you. The fifth and the last. Can you see the arterial one? This is the point of origin. Can you see the venous one? This is the point of origin. Arterial one, after the point of origin, it is growing in opposite direction to that of blood flow. You can see the blood is flowing here and it is growing there. It is known as retrograde propagation. After the point of origin, it is moving in opposite direction. But the venous one, after the point of origin, it is moving in the same direction. See the direction of the blood flow. It is known as antegrade propagation. Everyone give me a thumbs up if you got it. So these are the differences between arterial and venous thrombus in front of you. Can we revise quickly? Fadafat, the 5 differences, please help me. So arterial thrombus and venous thrombus, in the way of the diagram you can learn it. If I show you this difference table directly without this diagram, you will read the difference table, you will understand it, but you cannot imagine and you cannot memorize in the exam. But with the help of diagram, now you will have a pictorial memory in the exam that yeah, ma'am have shown us a diagram, the arterial side was yellow color, the venous was red color, and you can make it out. Okay, but we will see all the differences in this table also. So tell me the 2 type of the thrombus. You got it? What is thrombus? A clot formation in an uninjured blood vessel in an intact blood vessel. That is the definition of the thrombus. Okay. So arterial thrombus formed in the artery, venous thrombus formed in the vein. The arterial thrombus are white in color or pale in color because they have more platelet. The venous thrombus are red in color because they have more RBC. See their colors. Number 2, arterial thrombus are incomplete. That's why mural. You can see there is a space still left. And the venous thrombus, they are completely obstructing. That's why occlusive. See the second difference. Third difference, in arterial thrombus, alternate light dark bands are present. That is lines of Zahan are present. In venous one, these lines of Zahan are absent. The arterial thrombus causes ischemia to the organ because pure blood is not coming to the organ, and the venous thrombus causes edema to the organ because impure blood is not carried away of the organ. So ischemia and edema are the end results of arterial and venous thrombus respectively. From the point of origin, arterial thrombus go opposite. It grow in opposite direction. From the point of origin, venous thrombus grow in same direction as that of blood flow. So that's why arterial one are retrograde in propagation, the venous one are antegrade in propagation. Now I'm not reading this table, you already know all the points, I guess, and you can make the question out. Now read the question and tell me the answer. We will come on the question again. Read the question and tell me out. Conceptual learning. No rectification in my class, just understand the concepts. The complete pathology is like conceptual. You don't have to learn anything in pathology. It is such a beautiful subject. Okay, just understand the concepts, and question is like anything. It will be fun for you. Cakewalk. Read the question and tell me the answer. Come on. All of the following are true regarding arterial thrombus, except they are asking what is not true regarding arterial. Arterial grow retrograde, yes or no? You will say yes, ma'am, it grows in opposite direction. Lines of Zahan are present? Yes, lines of Zahan are present. Is it a white thrombus? Yes, it is white, yellow, white in color. Okay, but it is causing complete lumen obstruction? No. It is not complete. It is mural. Incomplete obstruction is there. So the incorrect among them is D. Got it? So this is how we have to approach. You get many questions on arterial versus venous. In front of you, I can make 20 more questions. Okay, but you can answer all if you know the concept. Coming on the next question in front of you, which of the following is an example of type 3 hypersensitivity? Which of the following is an example of type 3 hypersensitivity? Is it asthma, contact dermatitis, SLE or 𝗖𝗄𝗃? Yes. What is the correct answer? Tell me. Come on. The correct answer here is SLE. Okay, so it's time to perfect the topic hypersensitivity. Every year, mind my words, if you are a FMGE aspirant, now every year one hypersensitivity question is there. You can check any paper. Every year, you check your PYQs if you don't believe me. Every year you have a question on example of one of the hypersensitivity. There are 4 hypersensitivity. So learn the list of the 4. It's very easy. Type 1, 2, 3, 4. Learn the list out. One question you have secured in your pocket correctly. So let me give you the 4 list now. I will come on the question again. So let me give you 4 type of hypersensitivity. I'm not teaching you their mechanism, directly coming on the example. Basically, I'm giving you 4 mnemonics to learn the examples of 4 type of hypersensitivity. I'm giving you 4 mnemonics now. Okay, let's start with type 1 hypersensitivity. Let's start with type 1 hypersensitivity. In type 1 hypersensitivity, all the allergies will come. All the allergies will come in type 1 hypersensitivity. How many allergies you know? Eczema is a skin allergy. Do you know that? Hay fever is an allergy. You may be knowing that. Asthma, atopy is an allergy. Urticaria, anaphylactic shock is the most severe allergy. Acute dermatitis. You will say, ma'am, we all know the examples of the allergy. Allergy to sabko pata hai na. Ye sab allergies hain, kisko nahi pata. Everyone knows that. What do you don't know? The named reaction. These are the named reaction which makes you confused in the exam. So, I'm sorry. Putzner reaction. Cassoni test. Theobald-Smith phenomenon. These are the named reaction. These are also examples of type 1, but you forget that in the exam. So for that, make a mnemonic. The mnemonic is PCT. PCT क्या है? Proximal convoluted tubule. It's a mnemonic. So PCT. What does it stand for? P stands for Putzner-Kutzner reaction, PK reaction, very commonly asked PYQ. C for Cassoni test and T for 𝗬𝗲𝗃𝗏 phenomenon. So all these are type 1 apart from the allergy. So what does type 1 include? Type 1 include two things. Number one, all the allergy, as many as you can remember, plus PCT. What is PCT? Putzner-Kutzner reaction, Cassoni test, 𝗬𝗲𝗃𝗏 phenomenon. In the allergy, it is asthma, atopy, dermatitis, urticaria, anaphylactic shock, hay fever. So all these allergies are there. We already know the name. So don't make a mnemonic for that which you already know. Which you don't know, make mnemonic for that. Give me a thumbs up. Come on. Yes. Can we go ahead? Yes. Can we go ahead? So coming on the type 2 examples. Type 2 examples is my blood group is Rh positive. Say the full form. My stands for myasthenia gravis. Very commonly asked PYQ. Repeated. Blood B stand for blood transfusion reaction. In blood transfusion reaction, I mean both ABO incompatibility as well as Rh incompatibility. Rh incompatibility means erythroblastosis fetalis. That will also come here. So I am not saying erythroblastosis fetalis, but is already included in blood transfusion reaction. Okay. G stands for two ultra important things: Goodpasture syndrome and Graves' disease. Both are G. I stands for ITP, immunogenic thrombocytopenic purpura. R stands for rheumatic fever. H stands for hyperacute graft rejection, and P stands for pernicious anemia and pemphigus vulgaris. Okay, so that is my blood group is Rh positive. Coming on type 3. In type 3, the mnemonic is SHARP, SHARP. Say the full form. It's triple S. 3 S are there. One is serum sickness, one is sheik test, one is a sully. Okay, H stands for HS purpura. Okay, A stands for arthritis reaction, R for reactive arthritis, and there are two P. Both are ultra important, PAN and PSGN. PAN, polyarthritis nodosa, is a vasculitis, and post-streptococcal glomerulonephritis is a type of glomerulonephritis. And finally, type 4. The last one is the type 4. There is a mnemonic. John gave tulip popcorn to Hershey. John motor reaction. Tulip, tuberculin and lipramin. Q is tuberculin, lip is lipramin. Popcorn, pop is pernicious anemia, and corn is contact dermatitis, and Hershey is Hashimoto thyroiditis. So let me help you. Don't worry, I will help you again. Type 1, type 2, type 3, type 4. If you are reading it for the first time, at the first instant, it may be look difficult to you, right? But believe me, every year question comes from the examples of the hypersensitivity, and you cannot learn them without mnemonic. If you try to mug up directly, you will get confused. Okay, we will try again. In type 1, what is there? Can you help me in type 1? What is there? All the allergies are there along with PCT. Okay, in type 2, what is the mnemonic of type 2? What is the mnemonic of type 2? Just a second. In type 2, the mnemonic is my blood group is Rh positive. Okay, what is the mnemonic of type 3? It's SHARP, SHARP, in which triple S is there, double P is there. And what is the mnemonic of type 4 finally? The mnemonic of type 4 is John gave, what did he give? Tulip popcorn to whom? Hershey. To Hershey. So John gave tulip popcorn to. You want me to say the full form? Please try the full form by yourself. Okay, I can say it, but it will take the time. So please learn the full form. You definitely get the question on that. Now have a look on your question and you can make it out. What is the correct answer? Okay, so let's come on the question again and you yourself try. Which of the following is an example of type 3 hypersensitivity? They are asking type 3 hypersensitivity. First tell me the mnemonic. The mnemonic is SHARP. It's triple S and double P. Now tell me, is it asthma? No, asthma is one of the allergy. It's type 1. Is it contact dermatitis? No, contact dermatitis is type 4. John gave popcorn. Popcorn ka C hai. Corn ka C is contact dermatitis. Is it autoimmune hemolytic anemia? Autoimmune hemolytic anemia is type 2. It is coming in blood transfusion reaction. You can consider one of the anemia there. And SLE will come here in type 3. So correct answer is SLE. You got it? Okay. You got it. You get many questions on that. Coming on the next topic. The next question. Very important topic. Which of the following is the most common Hodgkin's lymphoma? Tell me the most common Hodgkin's lymphoma. Nodular sclerosis, mixed cellularity, lymphocyte depleted or lymphocyte rich? What is the correct answer? What is the correct answer? Yes, the correct answer is nodular sclerosis. If I am saying nothing, I am considering in the world. But if I change the question, most common Hodgkin's lymphoma in India, The answer will change. Okay, before asking you the two questions in the world and in India, let me explain you the next topic, Hodgkin's lymphoma. It's time to perfect the next topic, Hodgkin's lymphoma. Most of the students find this topic difficult. I will make it very easy for you. So start from the basic. What is lymphoma? How many types of lymphoma are there? Start from the basic. How many types of lymphoma you know? In lymphoma, the lymph nodes get enlarged. You know, the lymph nodes get enlarged and there are malignant tumor cells inside the lymph nodes. Blasts are present, malignant tumor cells are present inside the lymph nodes. That is lymphoma. The solid discrete organs get enlarged. Lymph nodes are enlarged, the liver, spleen, you can get solid discrete tumors. There are two types of lymphoma, Hodgkin's and non-Hodgkin's. So students even don't know the basic difference. What do you mean by Hodgkin's lymphoma? What do you mean by non-Hodgkin's lymphoma? Now in Hodgkin's lymphoma, there is a very peculiar cell is always present, RS cell. What is the full form of RS cell? Reed-Sternberg cell. Who is Reed-Sternberg? These are the scientists who discovered it. Reed-Sternberg cell. RS is the name of the scientist. Reed-Sternberg cells are present here. And here RS cells are absent. So RS cell is the basis of classifying Hodgkin and non-Hodgkin. So if you find any lymphoma patient, take the biopsy. In the biopsy, look for the RS cell. If the RS cells are present, it's Hodgkin. If the RS cells are not present, it's non-Hodgkin. So first thing, the basis of the classification is RS cell. What is RS cell? It's Reed-Sternberg cell. If Reed-Sternberg cell present, it's Hodgkin. If it is not present, it's non-Hodgkin. Say yes. Got it? Right. The first thing, the very first thing. Now let's come on Hodgkin's. We will discuss Hodgkin's in detail. For understanding a Hodgkin, you have to understand RS cell. Without RS cell, there is no Hodgkin. RS cell is a prerequisite for Hodgkin. So how many types of RS cell are there? There are 4 types of RS cell. The names are in front of you. Let me tell you. The first is the classical RS cell. The second is the lacunar RS cell. The third is LH, lymphohistiocytic variant of RS cell, also known as popcorn RS cell. And the fourth one is the pleomorphic RS cell. So you can see the 4 types of the RS cell. Classical RS, lacunar RS cell, lymphohistiocytic variant of the RS cell, and pleomorphic RS cell. Let me tell you the description of them. Let's start with RS cell. Classical RS. You can see classical RS cell is a binucleate cell. You can see the 2 nucleus, and inside each nucleus you can see a prominent nucleoli. And you can see the cell is very big with eosinophilic abundant cytoplasm. It's looking like owl eye, ullu ki aankh. You can see, have you seen an owl? The owl's eye, the big owl's eye. It's looking like that, right? Because it is binucleate, the 2 nucleus are mirror image of each other. It's classical RS. Always compare classical RS with owl's eye appearance. Owl's eye appearance, it's also a PYQ. So classical RS cell looks like owl eye appearance. The nucleus is always binucleate. Inside each nucleus there is a prominent nucleoli. The cytoplasm is abundant, eosinophilic, and the cell is very big. This is classical RS. Let's come on the next RS cell. Can you see the next RS cell? This is the boundary you can see. Oh no, this is the cell. It's a relatively small cell. It's a relatively small cell with 1 or 2 nucleus. 1 nucleus can also be there, 2 can be also there. And inside the nucleus you can see a prominent nucleoli. See, this is the nucleus, this is a prominent nucleoli, and hardly you can see any cytoplasm, a little bit cytoplasm. So see the 3 layers, cytoplasm, nucleus, nucleoli. You can see the 3 things. Now the point is that around the cell there is a clear lacuna. Can you see the white colored lacuna? Lacuna is present around each cell, a clear lacuna, white lacuna is present around the cell. That's why it's known as lacunar. So this is the second type. Okay, coming on the third type. The third type is the lymphohistiocytic variant, LH variant. Lymphohistiocytic. Here the nucleus is multilobated like the neutrophil. You know, multilobated nucleus is there, and inside each lobe a prominent nucleoli is present. It's looking like a popcorn. Have you seen a popcorn? It's looking like a popcorn. That's why LH cell is also known as popcorn cell. It is also known as popcorn cell, lymphohistiocytic variant. And the fourth and the last one, you can see multiple nucleus are present and there is no fixed morphology. It's pleomorphic. So what are the 4 types of RS cell? Tell me, what are the 4 types of RS cell? The first is the classical, the second is the lacunar, third is the LH or popcorn variant, and fourth is the pleomorphic. Now you got the RS cell, you will get the Hodgkin lymphoma now. Let's start the classification of Hodgkin's lymphoma. How many types of Hodgkin's lymphoma are there? Hodgkin's lymphoma are of 2 types. Classical Hodgkin, non-classical Hodgkin. I will tell you why we are classifying. Classical Hodgkin's is further of 4 types and non-classical is 1 type. Total 5 types of Hodgkin's lymphoma are in front of you. Total 5 types of Hodgkin's lymphoma. 4 are classical, 1 is non-classical. You will say, ma'am, what is the difference between classical and non-classical? Okay. All Hodgkin's lymphoma have RS cell. Do you believe or not believe? Yes, that is the basis of classification of Hodgkin and non-Hodgkin. Hodgkin's lymphoma have RS cell, non-Hodgkin's don't have RS cell. So if RS cell is present, it means Hodgkin. So here also RS are present, here also RS are present. But here in classical, the RS cells which are present, they are CD15 positive and they are CD30 positive. So that is the immunochemistry I'm telling you of RS cell. Here the non-classical, they are CD15 not positive, they are CD15 negative, I mean. They are CD30 negative, I mean, right? And they are CD20 positive. They are CD20 positive. They are BCL2 positive. Okay. So here they are 𝗲𝗵 positive. So their immunochemistry is different. So based on the immunochemistry of RS cell, we divide classical and non-classical. Okay. In classical, it's CD15-30. Very important question. In non-classical, no 15, no 30. It's 20 and BCL2. So in classical, what are the variants? There are 4 variants now. Nodular sclerosis, NS, mixed cellularity, MC, lymphocyte rich, lymphocyte depleted. You can see these are opposite of each other. One is lymphocyte rich, one is lymphocyte depleted. Here in non-classical, only one type is there, lymphocytic predominant. Now you don't get confused between lymphocyte rich and predominant. I know the meaning is same. The meaning is same. The morphology is also same. If you see their biopsy, it's almost same. But the RS cell is different now. You can see here the RS cell is CD15-30 positive and here the RS cell is CD15-30 negative. One is lymphocyte rich and one is lymphocyte predominant. You got my point? So please learn the types of Hodgkin's lymphoma. Now have a look here. Can you see the 5 types of the Hodgkin's lymphoma? This is nodular sclerosis, this is mixed cellularity, this is lymphocyte rich, this is lymphocyte depleted. These 4 are classical. These 4 are the variants of the classical. Okay, and the last one, lymphocytic predominant. Lymphocytic predominant. Okay. This is non-classical. Okay, so what is the difference? This is CD15-30 positive, 15-30 positive, 15-30 positive, 15-30 positive. But the last one is 15 negative, 30 negative, it's CD20 positive, BCL6 positive and 𝗲𝗵 positive. Say yes, everyone. Okay, got it? Say yes if you got it. Okay, so this is the first difference. You have to see the 5 types of the Hodgkin's lymphoma. Actually, 4 of them are classical and the last one is non-classical. Now you get ultra important many questions from this table. It's a master table. I can guarantee any question of Hodgkin's lymphoma you can make out from this table, but understand this table. Please learn them in a sequence. Don't try to change the sequence. Okay, tell me among the 5 types which is most common in the world, which is most common in the India, which is most common in HIV. 3 questions, 3 answers. Most common in the world is nodular sclerosis. Most common in the India is mixed cellularity. Nodular sclerosis is second most common in India. And most common in HIV is lymphocytic depleted. Please learn the most common. Most common in the world, most common in the India, most common in the HIV. Let's talk about male and female. Let's talk about male and female. So all of them are more common in male as compared to female, except nodular sclerosis, which is equal in male and female. Very important PYQ. Please learn my point. Examiners love exception. Whenever there is exception, please learn it, because examiner more probably ask a question on the exception. So nodular sclerosis is an exception where male is equal to female, in rest of them male greater than female. Right, that is the incidence wise, prevalence wise. Now coming on the type of RS cell. Now I told you there are 4 types of RS cell. You will say, ma'am, yes, the 4 types, but the lymphomas are of 5 types now. So one will be repeated. Okay, so nodular sclerosis have lacunar type. There is a lacuna. I told you the diagram. Mixed cellularity and lymphocytic rich. Both of them have classical, the aula appearance. Okay, lymphocytic depleted one have pleomorphic one. It is having pleomorphic one, and lymphocytic predominant have popcorn. The non-classical will have popcorn type, that is LH type. Ultra important PYQ on these things. Please, the type of RS cell, which Hodgkin's lymphoma. Please draw the diagram of all 5 here. I told you the diagram now. So which one of Hodgkin's lymphoma have which type of RS cell? So Hodgkin's lymphoma are of 5 type, but RS cell are of 4 type. So these 2 are repeated here. You can see. So 4 type of RS cells are there. Got it? The first and last is not associated with 𝗵𝐶𝗵𝗃 virus. The remaining 3 are associated with 𝗵𝐶𝗵𝗃 virus. I mean to say nodular sclerosis and lymphocytic predominant are not associated with 𝗵𝐶𝗵𝗃 virus. That's why their prognosis is excellent. You can learn like that. Both of them have excellent prognosis. The remaining 3 have not very good prognosis. The worst among them is in the HIV one. That is lymphocytic depleted is the worst. The first and the last is the excellent. Age wise. So this one occurs in adolescence, rest all occurs in old group. This one is biphasic, on which PYQ come. Which one is biphasic? Mixed cellularity is biphasic. So learn the most common, learn the male, female, learn the age, learn the RS cell, learn the immunophenotypic of RS cell, learn 𝗵𝐶𝗵𝗃 virus and prognosis. Can we make this table together? If you help me, we can make it again and try to mug up the things. So tell me the types of Hodgkin's lymphoma. There are two types of Hodgkin's lymphoma, classical and non-classical. Okay, classical are of how many type? Classical are of 4 type. What are the 4 types? Nodular sclerosis, that is NS, mixed cellularity. Okay, nodular sclerosis, mixed cellularity, lymphocytic rich, lymphocytic depleted, and non-classical have only one, lymphocytic predominant. So first write their names in the sequence, try it out, okay, because otherwise you will get confused. So first tell me most common in the world. Which is the most common in the world? This one is the most common in the world, that is nodular sclerosis. Most common in India is mixed cellularity, okay, and most common in HIV is lymphocytic depleted. Okay, this is the most common sequence you can see. Now tell me male and female. So all of them are more common in male as compared to female, all of them, except, learn the exception, nodular sclerosis, in which male is equal to female. Tell me age-wise. Age-wise, learn only one. This one is biphasic. Many questions asked on that. PYQ. Mixed cellularity one is biphasic. Tell me their RS cell, the ultra important. Which one is having which RS cell? So nodular sclerosis have lacunar type of RS cell. Mixed cellularity, lymphocytic rich. They both have classical type, the owl eye appearance, classical type. Lymphocytic depleted have pleomorphic type, you know, multiple nucleus, pleomorphic. And non-classical, that is lymphocytic predominant, have popcorn type. The other name of the popcorn is LH. You get many questions on that. You believe me, please trust me. Many questions on that. Please learn that. Now tell me the immunophenotyping of all of them. It's easy to say the immunophenotyping now. So these all 4 I'm writing together. They all are CD15 positive and CD20 positive. But the last one is CD15 negative. I'm sorry, this one is not 20, it's 30. CD15 negative, 30 negative, but CD20 positive and BCL6 positive. So please learn the immunophenotyping, ultra important, right? The next is the Epstein-Barr virus association. The first and last not associated with Epstein-Barr virus. The middle 3 are associated with Epstein-Barr virus. That's why the first and last have excellent prognosis and the middle 3 do not have good prognosis. The worst among them is the HIV one, that is lymphocytic depleted. That's all about it. Everyone give me a thumbs up. I tried hard to explain you the topic Hodgkin's lymphoma. You get many questions from that. Shall I come on the next topic? So before coming on the next topic, I want to tell you something, a small proverb, right? To change your life, you need to change your priority, right? Everyone wants a good life. Now, what is your priority in your life right now? You all are, I guess, medical aspirants. So some or other exam you may be preparing. So you want a good rank in your exam. Of course, you all want, so that you can get MD or MS or post-graduation from your dream branch. So in your dream branch, there are 19 options. From the 19 options, what do you want to become? Do you want to become a dermatologist? You want to become a radiologist? You want to become a pathologist? You want to become an obstetrician? You want to become what? Everyone have different life. Everyone have different work to do, but different work assigned. Which work is of your choice? You may have worked in various OPDs during your internship, or you may have seen. So you may have certain choice now. Now you want MD or MS? You want to become a physician or you want to become a surgeon? Are you good in scalpel or you are good in stethoscope? I mean, the person who is good in scalpel cannot be good at the same time in stetho. The person who is good in stetho cannot be good at the same time scalpel. So you want to become a physician or surgeon, that is the biggest difference in your life. You want to be, the person want to become MD cannot do MS by force also. The one who want MS like surgeon cannot become physician. So you will get your dream branch only if you get rank, good rank. If you are rank 1, imagine all 19 branches are available from the best possible apex institute, whatever exam you are targeting. Okay, so imagine that day, imagine you have rank 1. You know, that should be your life priority. To make your life like that, you have to change your priorities now. You have to do the sacrifices for a year, 2 ahead. You have to do ultra hard work. So the next 50 years of life, what you are going to live, that will depend on these 1-2 years, your foundation years. Okay, so that's all about it. Work hard and do smart work, not hard work. Decide your priorities in life right now. What is your priority? It should be crystal clear in your mind without any fogging. Okay, so let's go to the next question without wasting any further time. Can I start the next question? Are you people with me? Kindly respond. Can I start the next question? Okay, the next question is in front of you. Histopathological findings 12 hours after ischemic injury to the heart is. So they are asking 12 hours after ischemic injury to the heart, means they are asking about ischemic heart disease, or the question is regarding MI, myocardial infarction. The question is regarding MI, myocardial infarction. So histopathological finding 12 hours after ischemic heart injury or MI is what? Is it carrier excess of myocyte? Is it neocapillary invasion of the myocyte? Is it hypereosinophilia of the myocyte, or coagulation necrosis? What is the correct answer? Can you tell me what is the correct answer? Yes, the correct answer here, I'm sorry, it is wrongly marked. No, it's not C. The correct answer is the D. By mistake, it is marked as C. The correct answer is the coagulatory necrosis of the myocyte. Let me explain you MI completely. Okay, and the time zone of the MI. You get many questions, and students find this topic very difficult. So intentionally, I have selected those topics for this YouTube session in which students find much difficulty. These are the difficult topics of your syllabus from pathology. So let me simplify it, super simplify it. Okay, what is MI? What is myocardial infarction? Start from the basic. What is myocardial infarction? So for that, I have to draw the diagram of a heart. Let me draw the 4 chambers of the heart. This is a heart. The heart is having the 4 chambers. So this is left auricle, left ventricle, right auricle, right ventricle. I am interested in the wall of the left ventricle. Okay. Now what is the blood supply here? From the left ventricle, the aorta is coming out, the pure blood, and it supplies pure blood throughout the body, right? From the aorta, one of the branch of aorta is coronary artery. One of the branch of the aorta is coronary artery that supplies blood supply to the wall of the heart, the wall of the left ventricle and the wall of the heart. So these are the coronary arteries which are supplying the blood. Now imagine if there is any obstruction in the coronary artery. I'm drawing a rough diagram to explain you the concept. Imagine there is an obstruction in any of the, there are 2 coronary arteries, right and left. The right don't have any further branch, but the left is having 2 branches. So there are total 3 coronary arteries. Left circumflex, left anterior descending, and right coronary artery. So there are 3 and they have multiple further branches. If there is obstruction, what will happen? You will see less blood will be received to the wall of the left ventricle. So wall of the left ventricle have cells. These are known as myocytes. These cells are known as myocytes, cardiomyocytes, of course. So if they don't get the blood, any organ, if it don't get blood, it start necrosis, it start dying, it start necrosis. Necrosis is one of the cell death. Now it will start bursting and dying. So that zone of the left ventricular wall that is not getting the blood, that will undergo death. Imagine these cardiomyocytes are dead. So this portion is infarct and it is known as myocardial infarct. So this portion become non-functional permanently. You cannot retrieve it back because the dead cell cannot be retrieved back. In this area, the group of the cell is dead. I told you apoptosis is of a single cell, but necrosis is of a group of cell. So here the complete group of cell, depending it's a small infarct or a large infarct. This complete group of cell is non-functional because it is dead. Now what is the job of the left ventricle? What does left ventricle do? You will say, ma'am, it contracts, it relaxes. So there is a systole, there is a diastole. Whenever there is a systole, the blood ejected out in the aorta and distributed in the body. Now during contraction, this portion is not participating because it is dead. It is dead. This portion is dead. So when the left ventricle is contracting, this portion in the wall is not participating, not depending on how big is the infarct. So that's why systole is not very strong. It's very subtle. So the blood will not ejected in the aorta. So all the organs are not receiving the blood. So all the organs will go in hypoxia or anoxia, right? So that can happen in MI. So these are the consequences. And where does the blood go? Blood will go backward in the left auricle. From the left auricle, it will go in the lung and causing pulmonary edema, causing dyspnea. So these are the symptoms of the MI I'm explaining you. So this is a basic of the MI. You got my point? This is the basic. Now my point is that imagine there is a patient. There was a patient and who is dead now. Yes, there is a patient, there was a person and who is dead now, right? So what is the cause of death? This person, we asked another person who was with this person at the time of the death. So that person is saying the person was having a severe chest pain on the left side and after that the person is dead. So the police is suspecting the cause of the death is MI. The cause of the death is MI, but the police is suspecting of foul play. They are not sure. So they bring the dead body for the autopsy, for the post-mortem, for the autopsy, right? Just suppose I am the doctor performing autopsy on this dead body, on this cadaver, okay, on this dead body. So what I do, I will take the heart out. My first responsibility to take the heart out and to look whether MI is present or absent, number 1. If I found the MI grossly, I have to make a slide. And I have to see the age of the MI. Maybe this MI is 10 years before the patient was having a heart attack. The wife of this patient is saying, yes, my husband was having MI, but it was 10-20 years back. Now the cause of death is what we don't know. So what is the age of this MI? Is it a recent MI, today's, tomorrow, yesterday's, or is it 10 years back? So finding age is very important. That is known as aging of MI. That can be done histopathologically. So that is my topic. So this timing or aging of MI is done only on dead patient. In live patient, we don't do heart biopsy. Come on. On the dead only, we take it out heart for autopsy purpose in medico-legal cases, and we make the slide. And for why we are making the slide of the heart infarct? To know the age of the MI. In case of, so the death certificate which I will, the postmortem report which I will release, I will write whether MI present or absent. If it is present, what is the age of the MI? Now the police will correlate the age of the MI and the age of the death are the same time, so they will consider the MI as the cause of the death. So this is all they will do. So aging of MI is important. So how to do aging of MI? So we divide the complete infarct into 10 time zones. First learn the 10 time zones, and then I will tell you 10 diagrams. Each time zone have a different diagram, different presentation, different morphology. So first is 0 to half hour, then half to 4 hour, 4 to 12 hour, 12 to 24 hour. So this is R, 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. Now 24 hour is 1 day. So 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. Day. 14 days 2 week. So 2 to 8 week and more than 2 months. So see, the first 4 are the hours, then days, and then weeks. Try to write it down. Try to learn like this. So 0 to half hour, okay, half to 4 hour, 4 to 12 hour, 12 to 24 hour. These are hour, okay. 24 hour is 1 day, 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 days. So these are days, and 14 days is 2 week. So it's 2 to 8 week, and 8 week is 2 months. So more than 2 months. So these are the 10, count total 10 zones are there. Now I'm showing you 10 diagram. You just look the diagram, learn that findings in the diagram, and based on that you decide the time zone. So whatever is showing, so let me tell you. So 0 to half hour, it's impossible to diagnose the MI. We cannot diagnose, the heart look normal only. If you take the infarct and make a slide, it will look normal. Normal heart, you cannot detect it. It's a PYQ up to 30 minutes, you can miss it, up to 30 minutes. Okay, after 30 minutes, the morphological changes will be there. The first change is waviness. Can you see this is waviness? See the lower half. It's normal only. The only thing you can see the cardiomyofibers. Can you see the cardiocytes are there? These are the cardiac cells. Cardiomyocytes are there. You can see the nucleus is there. You can see the striations is there. You can see in the cytoplasm there is striation. So they are normal. The only thing they are wavy. Normally they are straight. Right, the only finding is wavy. So the first finding we get is waviness. It's a PYQ. The earliest finding in MI, which occurs at 0 to 4 hour, half to 4 hour, it's waviness. 0 to half hour, it's missed, it's normal. Say yes. Please on every point give me a thumbs up if you get it. Okay, so it's waviness. From 4 to 12 hour, coagulative necrosis is there. Now see the upper half of this diagram. Can you see the upper half? In the upper half, compare it with the lower half. Waviness is still there. But what is there? There is no nucleus. The nucleus of the cells is gone. And we can see the pink cytoplasm. And cytoplasmic striations also gone. So all the cells are undergoing coagulative necrosis. All the cells. So coagulative necrosis is there. Only coagulative necrosis. 12 to 24 hour. Along with coagulative necrosis, few neutrophils are present. You can see few neutrophils are also present here. You can see all of them are multilobated cells. These are the few neutrophils. After that, coagulative necrosis is there, but brisk neutrophils is there. So abundant of neutrophils. You can see coagulative necrosis is there, but you can see that cells are abundant, neutrophils are abundant. After that, neutrophils will try to decrease and macrophage will come. What does the macrophage will do? They will eat the dead muscle. All the dead muscle, the dead necrocytes, they will eat, and granulation tissue is formed. Okay, so you can see these are the macrophage. Let me highlight. Can you see this cell? This cell, they have only one nucleus, not multilobated. So these are macrophage. They start eating the dead muscle, and this, you can see the lower half. The dead muscle is present, but upper half, the dead muscle disappear. So this is granulation tissue. So granulation tissue is formed. Finally, granulation tissue well established, and finally scar is formed. Give me a thumbs up if you got it. So this is the complete time zone. Let me help you in writing once and final and show you the question. So can you help me to write the 10 time zones? What are the 10 time zones? 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. So these are the hours. Okay, you tell me what will happen here. After that, 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. You have to learn. These are the days. So you have to tell me what will happen here. And 14 days is 2 week, 2 to 8 week, and more than 2 months. So this is week and this is month. So tell me, who will tell me? So 0 to half hour, say ma'am, it's normal. Nothing will happen. Half to 4 hour, what is the earliest finding? Say waviness. waviness will come. 4 to 12 hours after waviness, coagulative necrosis will happen. And after coagulative necrosis, a few neutrophils will come. 1 to 3 days, along with coagulative necrosis, abundant neutrophils will come. After that, neutrophils decrease and macrophage increase. It's a very important PYQ. Macrophage occurs at which time zone? So answer is 3 to 7 days. 3 to 7 days. Repeatedly asked question. Macrophage will eat the dead muscle. So granulation tissue first form and it will become more established. After that, scar and scar, collagen and scar. That's all about it. Give me a thumbs up. So this is the complete aging of MI. Aging of MI is an ultra important and difficult topic in pathology. Very few students understand the in-depth meaning of that. Why we are doing aging? For autopsy purpose, to find out the medico-legal cause, whether the MI is present or absent. If it is present, what is the age? So that police can correlate the cause of the timing of the death with the age of the MI. So for this purpose we are doing this, and this is the complete aging. Complete aging you can see. So whatever you are finding, make a slide, see the finding in slide. Just suppose you are getting brisk neutrophil, so write down in your postmortem report, I got MI and the age of MI is 1 to 3 days. Now it's the job of the police to correlate it with the death. If you find abundant, if you find macrophage, say the cause of MI is present, but the timing of MI is 3 to 7 days. You give a range. Okay, so this is the complete thing about it. Coming on the next question. Okay, the next question is in front of you. Can we go ahead? Can we go ahead? The next question is in front of you. Read the question, tell me the answer. Which of the following is pathognomatic feature for rheumatic fever? Again, we have already discussed once rheumatic fever. So they are asking pathognomatic finding in the rheumatic fever. Is it Eshkoff nodule? Is it anti-Eshkoff cell? Is it McCallum patch? And is it vegetations along the cusp? So all 4 things occur in rheumatic fever. All 4 are correct. But pathognomatic is 1. Pathognomatic means specific, means characteristic. What is the correct answer? Can anyone tell me? Yes, so Eshkoff nodules are there. So it's time to understand the detail of the rheumatic fever, the heart portion of the rheumatic fever. Quickly, for the students who have joined late, let me explain you this diagram. This was my first question also, right? So see, this is a child. This is a child. Rheumatic fever occurs in child. The child is having tonsillitis, right? Tonsillitis is very common in children and it is caused by a bacteria. The name of the bacteria is group A Streptococcus bacteria, gas bacteria. So the child is having tonsillitis or pharyngitis with group A Streptococcus bacteria. The child is having pain in the tonsil. The child is having fever. What will happen? The body will form antibodies against the bacteria. The antibodies are formed. The antibody will bind with the antigen, with the bacteria, form an antigen-antibody complex, and they are killed. You will say, then ma'am, what is the problem? The bacteria are killed. Yes, the bacteria are killed. Bacteria are not causing any trouble. They are killed. On the surface of the bacteria, the problem is that on the surface of the bacteria, there is an antigen. There is an epitope. The name of that is M protein. What is the name? M protein. Similar M protein, relatively similar M protein present on human 5 organ. The brain, the heart. Number 1, the heart. Number 2, the brain. Number 3, the skin. Just below the skin, it's subcutaneous tissue, and after that it's joints. You can see the 5 organ. So basically the antibodies which are formed against the bacteria, they become confused and they cross react with these 5 organs. They consider this is also bacteria because the antigen is same. You can see antibody is coming and binding here, damaging the human 5 organs. So you can see these are autoantibodies because they are killing or damaging body's own organ. This is known as molecular mimicry and cross reactivity. So 5 organs have 5 diseases. You may be knowing the name of the diseases. In hearts, there is rheumatic heart disease that I am going to explain you detail now. In the brain, there is Sandham's chorea. In the skin, there is erythema marginatum. You know, in the subcutaneous tissue, nodules are there, and in the joints, arthritis is there. Right. So in the heart, rheumatic heart disease is there, and the cluster of all 5 is known as rheumatic fever. The rheumatic fever is not one organ disease. It is a multi-organ involving 5 different organs in human body. Okay, it's a multi-organ autoimmune disease. Autoimmune disease in which bacteria is not causing the damage to the 5 organs. It's the autoantibodies which is causing damage to the 5 organs. These are the Jones 5 criteria I have already discussed. Currently, I want to discuss you the rheumatic heart disease. So in rheumatic heart disease, you know, in heart there are 3 layers: endocardium, myocardium, pericardium. In this diagram, you can see red is endocardium, black is myocardium, green is pericardium. Can you see the 3 layers of the heart? Endocardium, myocardium, pericardium. Which layer is involved? Can you tell me which layer is involved? Endo is involved, or myo is involved, or peri is involved? Which layer of the heart is involved in rheumatic heart disease? I am talking. Which one? All 3. Endocardium also involved, endocarditis, myocarditis as well as pericarditis. That's why it is known as pancarditis. Pan means all 3 layers are involved. So pancarditis means endocarditis as well as myocarditis as well as pericarditis. All 3 layers of the heart are involved. That is pancarditis. Now I will explain you all 3 layers one by one, the features of that. So we are studying rheumatic fever. In rheumatic fever, there are five organs are involved. One of them is heart, so I'm explaining you the heart in detail. In the heart, there are 3 layers. I'm saying all 3 layers are involved. So endocarditis, myocarditis, pericarditis, all 3 are there. So it's pancreatitis. So let me draw the endocardium. This is the endocardium. Okay, this is the endocardium. Let me draw the walls of the heart. Okay, this is endocardium, this is myocardium, and let's say this is pericardium. Okay, you can see the 4 chambers. Where are the walls? This is mitral wall, this is tricuspid wall, bicuspid and tricuspid. Tell me the wall. I'm interested in wall. Wall is made up of what? Endo or myo or peri? I'm asking you. Wall is made up of what? Endo or myo or peri? Yes, absolutely right, Yugal. It is made up of endo. It is made up of endo. The walls are made up of endo. So let me draw the endo, and only endocardium is present in the walls, not myo, not peri. The walls are made up of endocardium. That is my point. So I mean to say endocardium is of 2 types. The endocardium which is present over the wall is known as valvular endocardium. Valvular endocardium. You can see with purple color. And the endocardium which is present on rest of the heart, the rest of the 3-dimensional heart, you can see with red color. Okay, it is known as mural endocardium. So endocardium is of 2 types. Apart from which we have myocardium shown by blue color, and we have pericardium, outermost one, shown by green color. So all are involved. Both endo are involved. So both endo are involved. I mean to say the walls are also involved, because walls are made up of endo. So in rheumatic heart disease, walls are always involved, and when the walls are involved, there is vegetations on the walls. Okay, so we will talk about that. You can see here I have shown you endocardium, myocardium, pericardium, all are inflamed. Okay, in the endocardium you can see valvular endocardium and mural endocardium. I have given 2 headings. Valvular means walls are involved, and murals mean rest of the heart is involved. Let's start with valvular. Let's start with valvular endocarditis. What will happen in the walls? In the walls, can you see this diagram? In this diagram, where are the walls? Appreciate the walls. These are the walls. Bicuspid, tricuspid. Over the walls, small nodular vegetations are formed. Small nodular vegetations are formed. This is all not due to bacteria. This is autoantibodies which are destroying it. Small vegetations are formed. Mitral wall is most commonly involved. So the mnemonic is MATP, M-A-T-P. Most common is mitral, followed by aortic, followed by tricuspid. Least common is pulmonary. These vegetations are formed. They are multiple, and they are formed over the walls. Number 1. This is about the valvular endocardium. On the mural endocardium, you see the rest of the heart. The rest of the red color endocardium in the heart. So only one portion is involved here. Can you see this patch? This is known as McCallum patch. Very important PYQ. So McCallum patch is present in left auricle. You can see it is present in left auricle. In the left auricle, on the it's a 3-dimensional structure now. On the posterior side of the heart, on the left auricle, that endocardium, the complete endocardium is there now. That portion becomes wrinkled, and that is known as McCallum patch. So in the mural endocardium, the complete endocardium is not involved. Only the left auricle posterior wall, one patch is wrinkled. That is known as McCallum patch. So in valvular endocardium, vegetations are there. In mural endocardium, McCallum patch is there. Let's come on myocardium, the middle layer. What you can see in the middle layer? You will see, ma'am, in the middle layer, I can see again nodules, small nodules. These small nodules are known as Ashkoff bodies. What it is known as? That is our question right now. That is known as Ashkoff bodies. Ashkoff bodies. What are Ashkoff bodies? These are granulomas. These are granulomas. Let me zoom out one of the Ashkoff body. You can see this is Ashkoff body. I have given a zoom version. You can see it's a granuloma, inside which giant cells are also present. Ashkoff cell, anti-Ashkoff cells are present, and giant cells are present. Okay, so this is a granuloma. So this is Ashkoff body. And what about pericardium? What happens in pericardium? What is pericardium? You can see the space between the myo and pericardium is pericardial space. So this is endocardium, myocardium, and pericardium. I'm talking about this space. This space is known as pericardial space. We all have this space. In this space, a little amount of fluid is present, that is known as pericardial fluid. We all have this fluid, but that fluid is watery in consistency. It's like very thin water, and small amount of fluid is present. That is pericardial fluid. But in rheumatic fever, this pericardial fluid, it becomes fibrinous in nature. Instead of watery, the consistency becomes fibrinous. Fibrinous का मतलब होता है पैथोलॉजी में thready, हिंदी में कहें तो धागेदार. It will be like threads. Have you ever tried eating cheese, a cheese pizza? So when you stretch a cheese, it's like the threads. In the same way, it's like fibrinous. So fibrinous pericarditis is there. What it is there? Fibrinous. Hello everyone, am I back? There was some technical error. I guess it's working now. Is it? Yeah, I guess it is working. The one who are still there can respond in the chat box. Just let me confirm. If it's working, I will start the session ahead. Yes. Yes, it's working. Thankfully, it's working. Thank you. Let me see your chat. Let me see. Yes, thank you. Thank you for responding. Thank you. So, okay. So, let me continue. I'm really sorry. There was a technical glitch. So, I guess internet connection loss was there from my end. But now, thankfully, it's working. So, let's continue. No, it's not over. Let's continue. So, you can see here, we have seen the pancarditis. And in the pancarditis, I told you endocarditis, myocarditis, pericarditis, all are there. The master table is in front of you. But pathognomatic feature is only one. You know, just a second. Just a second. Give me 1 minute only. Why my pen is not working now? Just a second. Let me open. Oh, I guess I have to move to that question. Okay, so here we are. We were discussing this question. Okay, so here the pathognomatic feature is 𝗲𝗃 body. So let's move to the next question. Start a new question with a fresh this. So can I start? The next question is in front of you. 𝗏𝗏 spirals are characteristic of which of the following airway disease? The options are chronic bronchitis, emphysema, atelectasis, and bronchial asthma. So what is the correct answer? Can you please tell me what is the correct answer? Is it chronic bronchitis, emphysema, atelectasis, or bronchial asthma? So all of them, the four options are COPDs. Chronic obstructive pulmonary disease, the ultra important topic. You frequently get questions on COPDs, one of the COPDs in your exam, and all of them are important. Currently, the question is on 𝗏𝗏 spiral. So what is the correct answer? Can anyone tell what is the correct answer? The correct answer here is the bronchial asthma. In bronchial asthma, 𝗏𝗏 spiral are seen. I will come on the question again. Let me explain you the sputum findings in a case of bronchial asthma. So bronchial asthma is a hypersensitivity. It's a type of allergy. It's type 1 hypersensitivity where the patient have three features. What are the three features of asthma? What are the three symptoms of asthma? The patient have cough. Okay, the patient have dyspnea, difficulty in breathing, and the patient have wheeze. A typical sound is created during breathing. Okay, so cough, dyspnea, and breathe. So whenever the patient is having coughing, now the patient has sputum in the cough. So try to collect the sputum of an asthma patient in a container. Okay, this is the sputum of asthma patient in a container. We are taking the sputum in a container and we try to make a smear of this sputum. So try to make the saline suspension of the sputum, make a smear of the sputum and try to see the microscopic finding. So if you take the sputum of an asthma patient and try the microscopic finding, you see 𝗏𝗏𝐶. Yes, you see 𝗏𝗏𝐶. That is the ultra important thing in asthma. What is the 𝗏𝗏𝐶? One is 𝗏𝗏 spiral, one is Charcot-Leyden crystal, and one is Crayola bodies. 𝗏𝗏 spiral, Charcot-Leyden crystal, and Crayola bodies. I will explain all three. What does it mean? So let me draw a respiratory tract in front of you. For example, just a second. This is a patient, and this is the respiratory tract I am trying to draw. So this is the nose. This is the pharynx. This is the trachea I am drawing. Okay. This is okay. A second. This is the trachea. These are the bronchi, and these are the lungs. Okay. So these are the cells of the tracheobronchia. So whenever the patient cough very vigorously during asthma, we are talking. Whenever the patient cough very vigorously, so if you try to collect the sputum, so sometimes what happen in the sputum, the complete strip of epithelia get shredded off, and complete strip of this epithelia is coming here. The complete strip of the epithelia is coming here. That is known as 𝗏𝗏 spiral. That is our question right now. What is 𝗏𝗏 spiral? The complete strip of the epithelial lining of the tracheobronchial tree during vigorous cough, it gets shredded and it comes in the sputum. Number one, it is in the form of a spiral strip. Sometimes what happen now, only single cell get degenerated and it is coming in the cough. That is known as Crayola body. This C is Crayola body, that is a single cell. And sometimes what happens in the sputum, you get diamond shaped crystal. You get diamond shaped crystal due to the eosinophilia, and these are known as charcoal-laden crystals. So that is the meaning of 𝗃𝐶. So Kochman spiral is degenerated respiratory epithelium, which is a twisted strip which is coming out. Cruella body is the single columnar cell which gets sloughed off and it is coming in the sputum. And charcoal-laden crystals are the diamond-shaped crystals due to eosinophilia. See them in the diagram. Can you see the sputum findings? In the sputum finding, try to see this, which I am highlighting right now. Can you see the strip? Please try to appreciate the strip. The complete strip, it is Kochman spiral. Okay, it is a respiratory epithelium degenerated which is coming out. Cruella body is not shown here, and you can see the diamond-shaped crystals due to the eosinophilia. See the background eosinophil. Because of the background eosinophil, diamond-shaped crystals are formed, which is known as Kochman spiral. So what are the 3C? What are the 3C? Can you tell me? Kochman spiral, Cruella body, charcoal-laden crystal. So it is the 𝗃𝐶, 3C in asthma. You get many questions on that. Now sometimes you get question on this. The answer is same, asthma. Say yes. Everyone got it? So correct answer is asthma. Coming on the next question. One more question on the COPD. All of the following are true about chronic bronchitis except. So what is the correct answer? Is it increased read index, subcutaneous gland hypertrophy, eosinophilic infiltrate of the airway, and bronchoria? What is incorrect? Eosinophilic infiltrate doesn't occur. I will come on the question again. Let me explain you what is chronic bronchitis. Now let me tell you, there are 4 COPDs, chronic obstructive pulmonary diseases. There are 4 types of COPDs. One of them is chronic bronchitis. One of them is asthma. One of them is emphysema, and the last one is bronchiectasis, in which bronchioles are involved. All of them are chronic obstructive pulmonary disease. The one thing is common in all of them, there is obstruction in the lower respiratory tract. So you may be knowing the complete respiratory tract, it's in front of you. Let me draw it once to explain you the basics of the COPDs. So let me draw the respiratory tract. Try to draw the respiratory tract. Start here, okay. So let me draw like this. Okay, so you can see here I have drawn. I start with the nose. After that there is larynx, there is pharynx, there is larynx. After the larynx there is trachea. From the trachea, bronchi, the main bronchi, right and left, 2 main principal bronchi come. From the bronchi, bronchioles will come. So first there is primary bronchiole, which give rise to secondary bronchiole, which give rise to tertiary bronchiole, which give rise to terminal bronchiole. It gives rise to respiratory bronchiole, then alveolar duct, then finally alveolar sac. I am writing, please everyone see. Primary bronchiole, secondary bronchiole, tertiary bronchiole, finally terminal bronchiole, then respiratory bronchiole, then alveolar duct and alveolar sac. And finally alveolar sacs, the balloon-like structures are there. This is complete respiratory tract. The last 3 structures. What are the last 3 structures here? Can you see the last 3 structures? That is respiratory bronchiole, alveolar duct, alveolar sac. This is known as acini. This is known as acini. The structural and functional unit of the lung is acini. Like the structural and functional unit of the kidney is glomerulus, na? Here it's acini. You can see this is acini. Okay, now this is the complete respiratory tract. The same thing is written in front of you. This is trachea, then bronchi, then bronchioles, first primary, then secondary, then tertiary, finally terminal bronchioles, then respiratory bronchiole, alveolar duct, alveolar sac. The last 3 structures are the acini. Now in all the 4 COPDs, the obstruction occur anywhere, but the level of obstruction is different, the reason for obstruction is different. For example, let's talk about this disease, chronic bronchitis. Here the obstruction occurs in trachea and bronchi. In chronic bronchitis, the obstruction occurs in trachea and bronchi. Now what is the reason for obstruction here? In trachea and bronchi, let me draw one trachea and bronchi for you. What is the wall of the trachea and bronchi? In the wall of the trachea and bronchi, you may be knowing there are 4 layers. The innermost is the epithelia, pseudostratified respiratory columnar epithelium is there. After that this is mucosa. After that this is submucosa. Just a second, I am interested in submucosa. Chronic bronchitis in which the submucosal glands will get hypertrophy. So this is submucosa. In the submucosa, glands are present. You can see these are the glands in the submucosa. After that, muscularis propria is there, and finally the serosa is there. You can see the 4 layers. Now in the submucosa, glands are there. What are the functions of these glands? These glands secrete a secretion, a sticky secretion throughout the respiratory tract. Now in our nose, starting from the nose, throughout the respiratory tract there is a sticky secretion that is secreted by the glands present in the submucosa, so that if any dust, any microbe, any foreign particle entering, it gets stuck here only, it don't go inside. That is the purpose of this secretion. Okay, it's normal, it's healthy. Now what happens? The God has given respiratory tract for breathing, but some people smoke. God has not given the respiratory tract for smoking, but some people is smoking. So smoke is causing an injury on the wall of the trachea. It is like acting like a stress. It is acting like a stress. So it is giving stress on the wall of the respiratory tract. Because of this stress in pathology, we always study whenever there is a stress, the body do the adaptations, right? There are 5 types of adaptations: hypertrophy, hyperplasia, metaplasia, dystrophy, atrophy, right? So here what happens now, the glands which are present in submucosa, they undergo hypertrophy and hyperplasia. I mean to say the glands increase in size as well as number. So glands increases in size as well as number because of the smoke. The smoke is acting as a stress on the wall of the trachea and bronchi. So the glands present in the submucosa undergo hypertrophy, hyperplasia. So they will do abundant of secretion. The abundant of mucoid secretion will form a plug, the mucus plug, and it will cause the obstruction. So the reason for the obstruction is the mucus plug, the excessive secretion of the glands. The glands doing excessive secretion because they are hypertrophic, they are hyperplastic because of the adaptation. So this is causing the obstruction. So every time patient cough and try to remove the obstruction. So while coughing, there is abundant of sputum. There are 2 types of cough, dry and with sputum, you know. So here the patient have abundant of sputum. Whenever the patient cough, abundant of sputum is coming, right? Because the patient is always trying to remove the obstruction, and after that also patient can't breathe properly. That's why patient have dyspnea. The most important complaint here is dyspnea. Now because of the dyspnea, patient have cyanosis. The pure blood is not there. So patient looks bluish in color. That's why these are known as blue blotters. Because of the cyanosis, these are known as blue blotters. So these all questions are on chronic bronchitis. You got the pathogenesis? Give me a thumbs up if you got the pathogenesis. You got the pathogenesis of chronic bronchitis? Just a second. Yes. So this is chronic bronchitis. Now here I would like to explain you the concept of the Reed index. The last thing is the Reed index. You got it here? Do you have any doubt here? Shall I tell you what is Reed index? Just a second. Let me tell you. Let me see your comments. Okay. So what is Reed index? Let me tell you that. Okay. Okay. So I would like to draw the 4 layers in front of you. For a normal person, for a chronic bronchitis. Here I am drawing normal. Here I am drawing chronic bronchitis. So here I am drawing the mucosa. This is mucosa. Okay. Here I am also drawing mucosa. So the main disease is in submucosa. So let's draw submucosa for both of them. Okay, this is submucosa. Muscularis propria is same in both of them. There is no problem in that. And serosa is also same in both of them. There is no problem in serosa also. So main disease occurs in the submucosa. So see in submucosa the glands are present on the lower side. So these are the normal glands. Okay, and here I am drawing the glands like that. Here I am drawing the glands like that. Okay, the glands are bigger. They are increased in number as well as size. So you can see the disease well. Very well, you can see the disease. Now let me tell you what is Reed index. Reed index is an index in which there is a numerator, there is a denominator. So what is the numerator? What is the denominator? Let me tell you. You calculate Reed index both sides. In the numerator, in the denominator, total thickness of the submucosa. So here also it's same. It's the total thickness of the submucosa. The denominator is same in both of them. But the numerator is the thickness of the submucosa which is having gland. So numerator is this here, and here numerator is this. So you can see numerator is more in chronic bronchitis because the glands is showing hypertrophy and hyperplasia. So I mean to say here Reed index is normal and here Reed index is increased because of increase of the numerator, that is thickness of the glands in the submucosa. So Reed index is an index in which the numerator is the thickness of the glands and total thickness is the denominator. Say yes if you got it. So do you have any problem? So this is chronic bronchitis. Then chronic bronchitis Reed index always increase. Now read the question and tell me the answer. Read the question. All of the following are true about chronic bronchitis except. So what is not true? You tell me what is not true. Increased Reed index? It is true. Reed index always increase. Submucosal gland hypertrophy? Yes. Submucosal gland hypertrophy as well as hyperplasia. It's true. Bronchoria? Bronchoria means whenever the patient cough, abundant of sputum is coming while coughing. So yes, it is also true, bronchoria. But eosinophilic infiltrate of the airway? No, inflammation hardly occurs. Here no inflammation, and eosinophilic infiltrate basically indicate asthma. Eosinophils come in allergy. Chronic bronchitis is not allergy, asthma is allergy. So this is a finding of asthma, not chronic bronchitis. Say yes if you got it. Can we go ahead? Okay. So let's come on the next question. The next question is in front of you. Which of the following is the most common RCC? Renal cell carcinoma. There are 4 types of renal cell carcinoma. All of them are your options. Is it papillary, clear cell, medullary, or chromophobe? Which of them is most common? Which of the following is the most common RCC? Yes, the correct answer is the clear cell. If I ask you second most common, answer become papillary. Okay, so let me tell you the types of the RCC. There are 4 types of RCC. Medullary is not a type of RCC, it is a type of thyroid cancer, and chromophobe is there. The 4 types of RCC are in front of you: clear cell, papillary, chromophobe, and collecting duct. This is most common in the sequence only. This is second most common, this is third most common, and this one is the rarest, the most rarest. Most common is clear cell. That is your question right now. You have to understand the genetic. Now the question is on most common, second most common, rarest. It's okay, you got it, right? The second thing, clear cell. Why clear cell is known as clear cell? Why? Because in this RCC you can see the cells, all are tumor cells. You can see no normal kidney. I cannot see any glomerulus, no normal kidney. It's completely sectioned from the tumor. Now in this tumor, I can see the tumor cells, all the tumor cells. I can see any cell. You can see the nucleus. You can see the cell boundary and nucleus. I can't see the cytoplasm. I can't see. The cytoplasm is clear. That's why it is known as clear cell. The cytoplasm is not pink, not blue. No eosinophilia, no basophilia. I can see clear cytoplasm. That's why it is known as clear cell RCC. Because of the clearing of the cytoplasm. Now you may be thinking, ma'am, why cytoplasm is clear? Because the cytoplasm contains abundant of glycogen. It's also a PYQ. It contains abundant of glycogen, and on H&E stain, glycogen don't take up the stain. That's why it looks clear. So this is the reason of clearing, and this is the clear cell carcinoma. It can be an image based question also, or spotter image. It's a RCC, clear cell RCC. It is the most common type. It arises from PCT. Okay, the cytoplasm is clear because of excessive glycogen present in the cytoplasm. You got it? Now the second question they can ask you on RCC is the mutation. You have to learn the mutation in all type. So tell me the mutations which occur. Okay, mutation part I will take in next question. Leave it here. Okay, let's come on the next question. The next question is on Mallory hyaline bodies are seen in which disease? Is it seen in acute viral hepatitis? Is it seen in Wilson disease? Is it seen in fulminant hepatitis? Or is it seen in all of above? So first thing, what is Mallory hyaline body? And tell me in which disease it is seen. Do you know the answer? What is the correct answer? Yes, what is the correct answer? Mallory hyaline bodies? Yes, the correct answer is the Wilson disease. Let me tell you everything about Mallory hyaline bodies. Mallory hyaline bodies, what are they? They are present inside the hepatocyte. First thing, they are present inside the liver. Inside the liver, there are hepatocytes. See these hepatocytes. Inside these hepatocytes, can you see the pink color cytoplasmic inclusion body? Try to see the cytoplasm. And in this cytoplasm, try to see the pink color eosinophilic bodies. Can you see this pink color? These all are Mallory hyaline bodies. So basically, Mallory hyaline bodies are irregular, rope-like, eosinophilic, pink color cytoplasmic string-like structures present inside the hepatocyte. They are made up of cytokeratin. To be specific, they are made up of cytokeratin 8 and 18. It's a PYQ. So that is the composition of Mallory hyaline body. It is seen in few diseases of the liver. So tell me the diseases of the liver, all the diseases of liver in which these are formed. So in some diseases of liver, this is a hepatocyte. This is the nucleus of the hepatocyte. In the cytoplasm of the hepatocyte, irregular, rope-like, pink color eosinophilic bodies are formed, and these are known as Mallory hyaline bodies. These are not normal. They indicate that the liver, the hepatocyte is having some disease. So name the disease. For that, I am having a mnemonic for you. What is the mnemonic? You can see the mnemonic is Indian child will have alcohol at primary bill. So these are the 6 diseases. Indian child is Indian childhood cirrhosis, the first disease. Okay, will is Wilson disease. That is our answer right now. Have is hepatocellular carcinoma. Alcohol is alcoholic cirrhosis. Alcoholism means alcoholic liver disease. That is cirrhosis, alcoholic cirrhosis. At, AT is antitrypsin deficiency. At means antitrypsin, AT deficiency. Primary bill means primary biliary cirrhosis, not secondary biliary. It's primary biliary cirrhosis. Say yes. So these are the causes of Mallory dank body. We will try to say the full form again. What is the mnemonic? Indian child will have alcohol at primary bill. Say the full form. Say the full form. Indian childhood cirrhosis, Wilson disease, hepatocellular carcinoma, alcoholic liver disease, alcoholic cirrhosis, AT deficiency, that is antitrypsin deficiency. Primary bill means primary biliary cirrhosis. So please learn the 6 diseases of the liver in which these Mallory hyaline bodies are formed. Okay, got it? So Mallory hyaline bodies are formed in these diseases only. Okay, not in other diseases. Now have a look on your question. You can answer it very easily. Among this mnemonic, only Wilson disease is given to you. Sometime to confuse you, you have one of the option as secondary biliary cirrhosis. So mind it, it is not seen in secondary, it is seen in primary biliary cirrhosis. Okay, so before coming on the next topic, let me tell you a small point, a small very good proverb. Exams do not test how much you read, exam test how much you retain. Very big thing. So whatever students do now, they keep on reading till end. They try to read the new content. What is most important? How much you have read, nobody is going to judge. How much you are retaining, exam is judging that. So they will give you the question in the form of the MCQ, and they will judge you how many of you are doing it correct. You know, you can do it correct only if you can retain in the exam. पढ़ सब लिया लेकिन वहाँ पे कुछ याद ही नहीं आया, तो पढ़ने का sense क्या है? The point is that revisions are ultra important. Don't miss revisions. Don't miss the revisions, you know. So if you have 5 months for preparation, give 2 or 1.5 months to the revision. So first 3 months, how much content you can read, how much, just read it. And in the 2 months, you do at least 2 time revision. At least 1 time is compulsory. If you can do 2-3 times, it's very good. So without revision, you cannot retain it. Just reading is not suffice. So what I have seen now, students try to complete all the 19 subjects till last time they try to read the new content. My sincere advice, in the last 20 days before your exam, don't read, don't even try any new content. Whatever you have read, just revise that, be confident. If you try reading any new content in the last 20 days, you are losing your confidence. You may be thinking, oh, I don't know this, oh, I don't know this. Confidence is the key to the success. So whatever knowledge you want to gain in the first 2/3 portion of your preparation. Last 1/3 portion of your preparation is exclusive for preparation. Whatever you have read, okay, read. Now this is the line. After that, you will not read any more new content. You will just revise it. This is the strategy. So try to finish your syllabus in the first 2/3 period of your preparation, whatever phase you are in your preparatory phase. Got it? So this is an advice. Go to the next question. Okay. The next question is regarding amyloid. No, it is regarding thyroid tumors. Amyloid stroma is seen in which thyroid tumor? There are 4 types of thyroid tumor. Everyone knows. Is it papillary, medullary, follicular, or anaplastic? What is the correct answer? What is the correct answer? Very important question, repeatedly asked. Amyloid stroma. So carcinomas of thyroid are very important topic. You frequently get questions on them, one of them. So correct answer here is of course medullary. Let me explain you the thyroid tumors. There are 4 types of thyroid tumors: papillary, follicular, medullary, and anaplastic. These are the 4 types of the thyroid tumor you can see. Let me discuss medullary first, and then I will show you the morphology of other 3 also. Let me first discuss medullary, which is our question right now. Now, human have a pair of gland, the thyroid gland, which is present in the neck. We all have this gland, okay? And there are 2 lobes in the gland, okay? Not pair of gland, it is only one gland, but the 2 lobes are there. The 2 lobes are connected with each other with the help of isthmus. We know that. Inside the gland, the cells are present. The cells are, there are 2 types of cells. The follicular cells are present everywhere, and in between, there are few parafollicular cells. There are few parafollicular cells. So I'm saying you there are 4 types of thyroid tumors now, 4 types. So the first 3 types arise from follicular, papillary, follicular, and anaplastic. They arise from the follicular cell, but only medullary carcinoma arise from parafollicular. Now parafollicular cell, what does they do? The parafollicular cells secrete calcitonin in the blood. The follicular cell form thyroid hormone T3 and T4. They synthesize that and secrete in the blood, and parafollicular cell form calcitonin and secrete in the blood. So I'm saying medullary carcinoma, it's a tumor of the parafollicular cell. That's why in all medullary carcinoma, calcitonin concentration will increase in the blood, right? So you can make a diagnosis from the calcitonin. Whenever they talk about the calcitonin, they are talking about the medullary carcinoma. This is the basic, I guess everyone know. In the diagram also, you can see these are the follicular cells, right? These are, so papillary carcinoma, follicular carcinoma, anaplastic carcinoma arise from them. But these are the parafollicular cell. Can you see these are parafollicular cell? So medullary carcinoma arise from it. So that is the thing, the first thing you have to understand. And here that's why calcitonin will increase. And in other 3 thyroid cancer, the T3, T4 will increase. Here calcitonin will increase. Among the 4 thyroid cancer, there are 4. Now only one is familial. This one is familial in association. Have you heard about MAN syndrome? MAN 1, MAN 2A, MAN 2B. So in MAN 2A, not MAN 1, MAN 2A and MAN 2B, medullary carcinoma occurs. Medullary carcinoma. So it is having a familial occurrence. It is also very important. You can see MAN 1, MAN 2A, MAN 2B. You get many questions on MAN also. MAN 1 is triple P, right? Triple P. See, सबसे पहले ऊपर pituitary. So pituitary adenoma occurs. उसके बाद parathyroid in the neck. Not thyroid, not thyroid. Parathyroid hyperplasia occurs in the neck. उसके बाद in the abdomen there is pancreas, pancreatic tumors. So P, T, P. तीनों का ट्यूमर, देयर इज ट्रिपल ट्यूमर. पिट्यूटरी का क्या है? एडिनोमा. पैराथायराइड का क्या है? हाइपरप्लेशिया. और पैनक्रियास का ट्यूमर. सो मैन 1 में देयर इज नो मेडुलरी कार्सिनोमा ऑफ थायराइड. थायराइड है ही नहीं. मैन 2A, मैन 2B both have it. Man 2A also have medullary carcinoma of thyroid. Man 2B also have medullary carcinoma of thyroid along with the other things, right? So learn it is having the familial association. Now coming on the morphology of the medullary carcinoma. Can you see this is a histological picture of medullary carcinoma in which you can see the tumor cells are there. These all are tumor cells. There is no normal thyroid. This is all tumor cells. The tumor cells are arranged in small nest. You can see they are arranged in small nest. Can you see this is one nest, this is a nest, this is a tumor cells are arranged in nest. The nests are separated from each other by fibrovascular septa. Can you make out the thin fibrovascular septa? See, I'm drawing the fibrovascular septa. These all are small nest. So first try to say the arrangement of the tumor cell. They are arranged in nest separated from each other by fibrovascular septa. Now take one of the tumor cell and describe it. So can you see one of the tumor cell? They all are uniform. There is no pleomorphism. They all look very same in size, same in morphology. There is uniform. Uniformity is a very big thing. Most of the tumor cells are non-uniform. I mean pleomorphism is there. Here pleomorphism is not there. Tumor cells are uniform with a prominent nucleus, central nucleus. The tumor cells are uniform. Now see the background. Background is ultra important. Can you see the background here? Let me show you what I want to mark. In the background you can see a pink color thing is deposited. See here the pink color background. Please concentrate on the background and concentrate on this pink color acellular structure. Pink color acellular structure in the background, that is amyloid. So it is a tumor in which the background stroma have amyloid, the pink color amyloid. So please see. So stroma have amyloid. The background, this is having amyloid. And the calcification is also very common. You can see the calcification, the blue color calcification. So what features? So looking at the slide, don't learn the theory, learn the slide. Now please make this clear in your mind. Please take a snapshot in your mind of the slide. This is a slide of medullary carcinoma. First say the arrangement. The tumor cells are arranged in nest. They are separated from each other by fibrovascular septa. All the tumor cells are uniform, looking same like. The nucleus is central in position. Okay. And the background is having a pink color structure, that is stroma, and calcification is common. Now you get many questions on that. That is medullary carcinoma of thyroid. Now how to test the amyloid? The stroma is amyloid. No? For amyloid we have a specific stain that is known as Congo red. Congo red. With the help of Congo red we can confirm it is amyloid or not amyloid. Just suppose I am having confusion, this pink color structure in the background, is it amyloid or not? Just perform Congo red. On Congo red the amyloid is pink color. If you see on light microscopy, it's pink color. You can see the pink. But if you see the same slide in polarized microscope, polarized light, you will see the pink convert into apple green. Jahan pink hai, it will convert into apple green. So on Congo, both are Congo red. This is. Only the microscope is different. Here after staining, we are looking in light microscope. And here after staining, we are looking in polarized microscope. So Congo red stain में amyloid light microscope में pink color का होता है. It is of pink color. And Congo red stain में the amyloid in polarized light become apple green color. So this is the diagnostic test for amyloid. If you have confusion, apply Congo red. It's a very important question. So we are done with medullary carcinoma. Let me tell you other three also. Okay, other three are at some other place. So coming on the next question now. Can I start the next question? Are you people with me? Are you people with me? Can I start the next question? The image shows the presence of what? Can you see the image? What is shown in the image? Is it 𝗲𝗏𝗃𝗃 body? Is it Hans body? Is it Cabot ring? Is it a Papanemer body? What is it? Can you please tell me what is it? In this image, I can see the RBCs. All these cells are RBCs. Can you see? All these cells are RBCs. Inside the RBCs, there are inclusion bodies. I can see the dot-like structure. In one RBC, only one dot I can see. So this dot-like inclusion body is what? What is the correct answer? Yes, it's 𝗲𝗏𝗃𝗃 body. You know how to differentiate the four. Let me tell you all type of RBC inclusion bodies at one place. The master table. I will come on the question again. So I'm going to teach you 5 things now. The 5 type of master table of inclusion body. In the RBC, 5 type of inclusion bodies can occur. Okay. RBC is a non-nucleated cell. We know that. Only hemoglobin is present at the periphery 2/3. So it can be 𝗲𝗏𝗃𝗃 body. It can be Papanemer body. It can be Haynes body. It can be Cabot ring. It can be basophilic stippling. Okay, so let me explain you the difference between all 5. You can see I have drawn the RBCs in front of you. In each of them, now 𝗲𝗏𝗃𝗃 body inside RBC, a dot like a blue basophilic dot is present. But the point is that it is one dot per RBC. It is not multiple, always 1 dot per RBC. It can be central and it can be peripheral. You can see here central can also be there, peripheral. So one I have drawn peripheral intentionally and one is central. It can be central. So in the diagram also here you can see this one is central, this one is peripheral, this one is peripheral, this one is central. But 1 dot 1 RBC. So that is 𝗲𝗃𝗁𝗁 body, right? That is 𝗲𝗃𝗁𝗁 body, and it is made up of the nuclear remnant. You know, RBC precursor have the nucleus. They gradually lose the nucleus, okay? But sometime a little bit of nuclear remnant is there. That is known as 𝗲𝗃𝗁𝗁 body. So it is representing nuclear remnant and made up of DNA, because nucleus is made up of DNA. So that is the composition. It is seen. So normally it is present in all of us. A few RBCs have nucleus remnant, but the spleen remove those RBC. Our spleen take care of it. We all have spleen. I'm having spleen. So if in my blood any of the RBC have 𝗲𝗃𝗁𝗁 body, my spleen will remove that RBC because it is abnormal, right? But the person in which splenectomy is done, they don't have spleen because of the splenic tumor, splenic trauma or anything. They don't have spleen. So there is no one to remove the 𝗲𝗃𝗁𝗁 body in them now. So splenectomy person mein 𝗲𝗃𝗁𝗁 bodies are common. So learn 𝗲𝗃𝗁𝗁 body, learn its morphology, learn its composition, learn the disease in which it is seen. You can get any question. 𝗲𝗃𝗁𝗁 body. Done. Pack. Coming on the next inclusion body, it is Pathologypyq body. Pathologypyq body. I will show you all images. Wait, okay. It is also present inside RBC, but they are multiple and they are present at the periphery. Can you see multiple at the periphery? Multiple at the periphery. See this one. See this RBC. The multiple at the periphery. Try looking it. Okay. These are made up of ferritin aggregates, the iron, excessive ferritin. Whenever there is excessive ferritin in the human body, it aggregates in the RBC at the periphery. So this is the composition, this is the disease. So this is the Pathologypyq body. See the morphology, see the composition, see the disease. Okay, coming on the third, 𝗲𝗄𝗃 body. 𝗲𝗄𝗃 body are also multiple, but they are not at periphery, they are present randomly anywhere. They are present randomly anywhere. They are not seen on H&E. So they all are seen in H&E except 𝗲𝗄𝗃 body, which is seen in supravital stain. So image will also be always be supravital. See this image. Can you see this image? It is not H&E. This is H&E, RBCs are pink. This is H&E, RBCs are pink. This is H&E, RBCs are pink. But here RBCs are green in color. It is supravital stain. So whenever they give you supravital stain, inside which you can see multiple dots. Supravital stain with multiple dots. It's 𝗲𝗄𝗃 body. It is indicating denatured hemoglobin. The hemoglobin is non-functional, it is denatured. And it is seen in 𝗙CE deficiency. Ultra important question. On all these, you believe or don't believe, you have PYQs in your exam. On all of them. So 𝗲𝗄𝗃 body, they are seen in supravital stain. They are multiple inside the RBC. RBC look green in color and these are blue inside the green RBC. They are made up of denatured hemoglobin and they are seen in 𝗙CE deficiency. Give me a thumbs up. Got it? Coming on the fourth one, 𝗃𝗏 ring. 𝗃𝗏 ring look like a ring of 8. Can you see figure of 8? 1, 2, 3, 4, 5, 6, 7, 8. So 8. It's figure of 8 inside the RBC. Okay. It is made up of iron and arginine rich histone. That is the composition. It is seen in pernicious anemia. Very important question. Last is basophilic stippling. Basophilic stippling is a stippling. Multiple small punctate dot-like structures are present inside the RBC. They are made up of ribosomes or rRNA, ribosomal RNA, and it is seen in lead poisoning. Very important question. Let me show you all 5 again. Everyone here on the screen. The first one, just a second. How it will go. Okay, can you see the first one? Not going. Just a second. Give me a minute. Okay. So can you see this one? So this one is 𝗲𝗃𝗁𝗁 body. You all can make it out. One inside one RBC, can be central, can be peripheral. 𝗲𝗃𝗁𝗁 body made up. It is showing remnant of the nucleus. So that's why it is made up of DNA and it is seen in splenectomy because spleen used to remove that. It is seen in splenectomy. Okay. The second is the Pathologypyq body. You can see the RBC. You can see at the periphery multiple dot-like structures are there. This is Pathologypyq body. Multiple dot-like structures at the periphery. It is made up of ferritin. The composition is ferritin. That's why in body, whenever there is ferritin excess, this is seen. Okay. The third is the 𝗲𝗄𝗃 body. 𝗲𝗄𝗃 body is not seen on H&E. No, they are not seen. So image is supravital stain. You can see the RBCs are green in color. Inside the RBC, multiple dot-like structures are there. Okay. Multiple dot-like structures are there and they are representing denatured hemoglobin. And they are seen in 𝗙CE deficiency, very commonly asked PYQ. The next is the 𝗃𝗏 ring. You can see inside the RBC, it's a figure of 8. It is made up of iron and histidine rich protein. Okay, and it is seen in pernicious anemia. Very important. Pernicious anemia mein hota hai क्या watering. The last one is the basophilic stippling. Can you see this RBC and this RBC, this RBC, inside which try to see the basophilic punctate like dot 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 multiple, and it is seen in specifically lead poisoning. Very important question. Can we go ahead? So you get many questions on inclusion body. We have done once for all. You know all inclusion body. You know their morphology. How does they look like? For image based question, you can get all 5 images. All 5 images. Image based question. Identify. Or else you get the same image and you get a question. Write the composition. Or else you get the same image. They will ask you the disease in which it is present. So in each image, I can give you 3 questions. So 3 into 5. I am having 15 questions for you in this master table. So they can ask you the image based question on this morphology. They will give you the image and they ask what it is. They can ask you the composition. They can ask you this disease in which it is seen. So 5 into 3, 15 questions are there on this page. Don't miss it. Don't try to miss it. Okay, so just revise it. Coming on the next question, what is the diagnosis? It's a spotter. Can you tell me what is the diagnosis? What is the diagnosis? It's a spotter. Yes? Who will tell me? So, is it lymphoblast, myeloblast, megakaryocyte or normoblast? See the big clue given in the question. These cells have the nucleus, but in the cytoplasm you can see some rod-like structures, red color rods. See the cytoplasm and appreciate these red rod-like structures. What is the correct answer? The correct answer is myeloblast. These are the iron rods. So, these you can see the cells, you can see the NC ratio, the nucleus is very big, cytoplasm is less, so these are tumor cells. These are not normoblast. These are not megakaryoblast. These are lymphoblast or myeloblast. Usme se bhi it is myeloblast because myeloblast have the iron rods. Lymphoblast don't have iron rods. Okay, so it's time to study leukemia now. The myeloblast, the lymphoblast, the classification of the leukemia. So next question is leukemia. What is leukemia? Many students even don't know what is leukemia. You tell me, how does WBC formed? You will say, ma'am, WBCs are formed in bone marrow. All blood cells are formed in bone marrow. So the first cell in the bone marrow which give rise to all WBC is hematopoietic stem cell. Hematopoietic stem cell. Okay, we all know that. From the hematopoietic stem cell, 2 blasts arise. The first blast is the myeloblast. The second blast is the lymphoblast. Myeloblast में से क्या-क्या बनता है? Neutrophil, eosinophil, basophil and monocyte. Lymphoblast में से बनता है lymphocyte. Total 5 type of WBC. 5 में से lymphoblast is formed, lymphocyte is formed by lymphoblast. The remaining 4 WBC, neutrophil, eosinophil, basophil, monocyte, they are formed from myeloblast. These are the basics, I guess everyone know. Okay, so these are the 2 blasts which give rise to these WBC. Having blast in the marrow is normal. I am having it, you are having it, we all have it. The blast in marrow, they give rise to the WBC. Once the WBC become mature, they leave the marrow and they come in the blood. The mature WBC come in the blood. If you take blood sample of any healthy individual, you get all 5 WBC. So having WBC, the mature WBC in the blood is normal. But when blast come in the blood, it is known as leukemia. So what is leukemia? The blast in blood. Having blast in marrow is normal, but having blast in blood is not normal. More than 5% blast in the blood is leukemia. This is the WHO definition of leukemia. Leukemia is blast in blood. Please learn in short. Okay. Now come on lymphoma. What is lymphoma? After coming in the blood, these blasts can enter into the solid organs. Maybe the spleen, maybe the liver, maybe the lymph node, causing discrete masses inside these solid organs. That is known as lymphoma. So lymphoma may be blast, lekin blast in the solid organs. So leukemia is a blood cancer. You will not get any mass, but lymphoma you will get discrete mass. So this is the basic concept of the leukemia and lymphoma. Now, in leukemia, I am saying the blasts are coming in the blood. Which blast is coming? Myeloblast is coming or lymphoblast is coming? We have 2 blasts now. So when myeloblast is coming in the blood, it's known as myeloid leukemia. Okay, and when lymphoblast is coming in the blood, it's known as lymphoid leukemia. So that is a basic classification. There are 2 types of leukemias, the blood cancers, myeloid leukemias, lymphoid leukemia. Myeloblast come, myeloid leukemia. Lymphoblast come, lymphoid leukemia. Each of them is of 2 type. Acute chronic, acute chronic. Okay, so acute myeloid, it's known as AML, acute myeloid leukemia. It's acute and myeloblast is coming. This one is known as CML. You got it. It's chronic and here also myeloblast is coming. Here also acute lymphoid leukemia, ALL. It's acute and lymphoblast is coming. And CLL, chronic lymphoid leukemia. So give me a thumbs up. These are the 4 types of leukemia. I hope you got it. So basically leukemia. What is leukemia? Leukemia is blast in blood. more than 5% of the blast in blood. This is leukemia, the WHO definition. Now, which blast is coming? Is it myeloblast which is coming in the blood, or is it lymphoblast which is coming in the blood? If myeloblast is coming in the blood, it's myeloid leukemia. If lymphoblast is coming in the blood, it's lymphoid leukemia. Give me a thumbs up. Got it? Okay, give me a gesture. You got it? Now, you tell me. It can be acute, it can be chronic, it can be acute, it can be chronic. Based on that, these are of 4 types. So what are the 4 types? This is acute myeloid leukemia, chronic myeloid leukemia, acute lymphoid leukemia, chronic lymphoid leukemia. So these are, so basic difference is myeloblast or lymphoblast. So whenever any patient of leukemia, take the blood sample out. Imagine I'm having a patient having the leukemia, one of the 4 leukemia, I don't know which one. So the first thing what I will do, I will take the blood sample out in a test tube and I will make a smear. I will make a smear of this blood, and in the smear, the first finding I would like to see, is it myeloblast or lymphoblast? If it is myeloblast, it's myeloid. If it is lymphoblast, it's lymphoid. Then acute or chronic we will see later on. Okay, so the difference between myeloblast and lymphoblast is ultra important. Got it? The difference. One is myeloblast, one is lymphoblast. Both are blast. You can see the difference. The myeloblast is little bit larger, you can see. Lymphoblast is little bit smaller. See the cytoplasm. You can see a little bit cytoplasm here. Let me show you. यहाँ पे तो भी थोड़ा cytoplasm है. You can see this one is cytoplasm, remaining is nucleus. Here hardly any cytoplasm. I can't see the cytoplasm. A very scanty rim of cytoplasm I can see. So here cytoplasm is moderate. Here it's scanty. Here iron rods are present in the cytoplasm. See red color rod-like structures. They can be present. They can be absent. It's not all of them have, but they can have. They cannot have. In lymphoblast they are always absent. The biggest finding. Here nucleus chromatin is fine. Here it's coarse. And here inside the nucleus you can get nucleoli, prominent nucleoli. Here nucleoli are absent. Now look at your image. This image is given to you in your exam. So they are showing you iron rod. It's with the arrow also they are showing iron rod. Iron rod matlab it has to be myeloblast. Say yes if you got it. Everyone got it? Say yes. So this is the picture of 4 type of leukemia in front of you, right? This is AML. It's myeloid, no? So myeloblast. You can see all the cells are myeloblast. All the cells are myeloblast. You can see they all are same, and in their cytoplasm the iron rods are there. Iron rods. Some of them have iron rods, some of them not, but all cells are same looking. They all are uniform. It's looking like a school uniform. Every cell is cell. So in the blood you get only myeloblast. So AML have only myeloblast and they have iron rod. Okay, ALL, it's lymphoid now. It's lymphoid. This one was myeloid, this one is lymphoid. So here only lymphoblast will come. See all these cells, they don't have cytoplasm, scanty cytoplasm I told you, and there is no cytoplasm, no iron rod. Again they all are same, like a school uniform. Like a school uniform they all are same, but these all are lymphoblast because they don't have iron rod. So here also school uniform, but they are myeloblast. Here also school uniform but lymphoblast. They have the iron rod, they don't have the iron rod. This is the basis of differentiating AML from ALL. Both are acute leukemia. Here also 99% of the cells are myeloblast. Here 99% of the cells are lymphoblast. Right? It's like school uniform appearance. I insist this word. They all are same, I mean to say. Okay. Coming on CML. The chronic version. CML, you can see it's a garden party appearance. Multiple cells are there. It's not one type. See here one type cell, here one type cell, but in CML multiple cells are there. I can see multiple cells. So CML, you will say ma'am it's myeloblast. M matlab myeloblast should arrive, na? Yes, I agree. Few cells are myeloblast, but along with myeloblast other cells also come from the bone marrow to the blood. So the other precursors also come. You will get promyelocyte, myelocyte, metamyelocyte, band form, all of them are coming. So it garden party appearance. So यहाँ पे only myeloblast है. यहाँ पे myeloblast के साथ other cells भी हैं. Myeloblast के साथ other cells are also present. So that is the difference between AML and CML. You got it? The last one is the CLL. These are the master diagrams I am telling you. Please believe me. CLL. In CLL there is no blast. Blast आता ही नहीं है blood में. Lymphocyte. The mature lymphocyte comes in the blood. Can you see? These all cells are mature lymphocyte. Mature, but these are not normal. These are abnormal lymphocytes. You will say, ma'am, what is abnormality? These are mutated. Okay, these are very fragile. So imagine I'm having a patient in my clinic, old patient, and I'm suspecting CLL in the patient. So what I'm doing, I'm taking the blood sample of this patient in a test tube. I want to make the smear, of course. So in the smear, I'm taking one drop here, and how we make the smear? You will say, ma'am, one drop and spread it with a spreader. Spread it with a spreader. So whenever you try to spread it with a spreader like this, you will try to spread it with a spreader like this. So here 99% of the cells are abnormal lymphocytes because the patient is having CLL. So 99% of the cells are abnormal lymphocyte. So lymphocyte will come in the smear. The lymphocyte during spreading, they just rupture. They are very fragile. Normal lymphocyte during spreading, they don't rupture. But here, since they are mutated, they are abnormal, they are very fragile. They just get rupture. They get rupture. These are known as smudge cells. So my point is that in the patient body, you get only lymphocyte. You get only abnormal lymphocyte, no smudge cell. But on the slide, along with the mature lymphocyte, the abnormal lymphocyte, you get smudge cell also. What are smudge cells? Smudge cells are the broken, they are the ruptured lymphocyte. It is the slide artifact. What word I am using? Slide artifact. It is not present in human body. While spreading, they are forming. So we can see the two things. These all are mature lymphocyte, and please concentrate these one. Can you see this one, the ruptured lymphocyte, that is known as smudge cell or basket cell. That is the hallmark to identify. See the master 4 diagrams. I have created this for you to understand the 4 types of leukemia in the shortest time possible. Say yes, you get many questions on that. Appreciate my hard efforts. Okay, hard efforts. So this is the 4 type of leukemia I have explained you. Any question coming on that, you can identify. And here I would like to stop. We have discussed many questions. I guess most important topics we have discussed. We can do more sessions of pathology, such sessions in which we can discuss the important topics question wise, and we can excel in the pathology like, right? So here I would like to stop. Thank you so much for being with me, giving your precious time to me, and I would wish best of luck to all of you for whatever exams you are targeting. Wishing you all the best. Okay, and now you have only 2 options. Either regret later or study now. The choice is yours. The choice is yours. Okay, either regret later or study now. Regret is a very bad feeling, even worse than failure. Sometimes you can accept the failure but not the regret. Failure is something you tried your best but God ने नहीं किया. I had given my best shot. But regret is काश किया होता. I wish उस समय पढ़ाई की होती, मस्ती नहीं की होती. So that is regret. Regret is worse feeling than failure. So एक बार failure चलेगा लेकिन regret नहीं चलेगा life में. So give your best shot. Whatever best you can do now, just do it. So after that selection occurs, it's good. Don't occur, you will not have regret. I had given my best. It's okay. So that is the thing. Thank you so much, and that's all about it. Hope to see you